going to appoint myself to the Budget and Finance Committee
It's caught.
so we could achieve a quorum. We have a quorum now.
All right. Good evening, everyone, and thanks for coming this evening. It is 5:34, and I'd like to call to order the Budget and Finance Committee meeting of the Central Health Board of Managers. It is Wednesday, April 17th. A little information about the agenda. We will not be taking up items number 7 and 8. And those items are 7, discuss and take appropriate action on the 1115 Medicaid waiver, delivery system reform incentive payment projects, the Community Care Collaborative, including healthcare delivery arrangements and other related community partnerships. And number 8, discuss and take appropriate action on an update regarding Sendero Health Plans Incorporated, including the effect of federal legislative and regulatory actions. We will take the agenda in the following order. We'll take agenda item number 1, agenda item number 5, agenda item number 2, agenda item number 3, agenda item number 4, agenda item number 6, and agenda item number 9. With that said, I would like to lay on the table agenda item number 1, consider and approve the minutes of the March 13th, 2019 meeting of the Central Health Board of Managers Budget and Finance Committee. Do I have a motion?
Yes, I so move that we adopt the minutes of the March 13th, 2019 meeting of the Central Health Board of Managers Budget and Finance Committee.
Second.
I have a motion from Manager Valadez. I have a second from Manager Greenberg. Any further discussion? All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. Okay, I would like to lay out item number 5, discuss permanent supportive housing projects for homeless Travis County residents. And before starting the presentations, I would like to lay out a plan for discussion for this model to address homelessness in Travis County. The information will be presented as follows. Mr. Giesland will present a timeline so that all the board members are aware of the actions and activities that have taken place up to this point regarding this model. Then I'll have Ann Howard and Councilman Kitchen and Nirva Shaw come up and provide an overview of the model. And then next, I will have Mike Giesland close the presentation with a summary of the CCC and the Central Health staff's evaluation of the model from the perspective of Central Health and CCC activities and investment. And finally, I'll open the floor for questions and comments from all the board members. I know that the presentations will provide a large amount of information for you guys to absorb. So I'd like to request that you write down your general questions and comments, and we'll address those at the end of the presentations. Some questions may need to be answered in closed session, and I will yield to our attorney, Holly Gummert, to regarding these questions and to let us know what needs to be done in closed session. We will complete all of our open session discussion and then go into closed session if necessary. I will allow members to be recognized for clarifying questions during the presentation. These are questions to ensure that you are understanding what the speakers are presenting. I would ask, however, that other hypothetical questions, in-depth general questioning, or comments should be written down and asked at the end of the presentation. As chair, I will reserve the right to take control of the floor if your questions go beyond clarifying to allow the presentations to keep moving, and I'll ask for each member to give me some cooperation with this. It's not my intention to prevent any member from having their questions answered or providing their comments regarding the model. But I ask that each member be cognizant of the time, make your comments as concise as possible, and keep your topics aligned with the agenda item. Permanent supportive housing projects for the homeless Travis County residents. Finally, I want the audience to be clear that Central Health currently provides a significant amount of healthcare services to the homeless in Travis County. And we do not foresee that there will be any changes in these service levels. This discussion is about a specific financial model to address homelessness. Central Health's participation or non-participation in this model will not have any effect on our current or future commitment to provide health care to the homeless population in Travis County. So with that, I will turn it over to Mr. Geisler.
Yes, members, I will briefly go over some highlights on the timeline that was in your packet. It's up on the screen right now. And note that this goes back to 2016, actually before 2016, when there's been quite a bit of interaction with ECHO on this. And I'll have to defer to others in terms of what that may have been. But just to give you some sense about how this is not, by any stretch of the imagination, a new issue for the newer board members. Second, I want to highlight two dates, and it explains in detail the actions that the board has taken to date. And that's the February 28, 2018 date and the March 28, 2018 date. For fiscal year 2018, the Budget and Finance Committee gave instructions to management to continue to start working on terms that would get us to a model similar to what ECHO has proposed or what ECHO has proposed. But that was just to begin working on terms. If you go back and look at the minutes, there is no mention in the minutes of a specific dollar amount. However, you go to the next month, on March 28th, and you see that there was a $400,000 allocation as recommended by Budget and Finance, meaning continue to work through these terms and come up with a workable program. So those are the formal actions that this committee and the board have taken to date. For FY19, there was an amount of $400,000 set aside in our contingent, new initiatives, and which is a line item in our budget. But think of that, the analogy I like to use is a worksheet exercise. That's really something that's done at the staff level. We're just plugging in amounts to be able to get new initiatives to a certain level. Understanding that we would still have to come back to the board for you all to allocate those funds for a specific program, especially in light of the discussion in 2018, which is you all wanted to see agreeable terms. So that summarizes the actions that the board has taken. I think recently, and I'm going to the bottom of the timeline there, there's been a lot of back and forth really focusing on the performance on this. I know through 2018 there was a lot of work around the programs and getting a better understanding of how it would work, and I want to thank the CCC staff for investing a lot of hours into that effort. But in January, then the attention's turned to the financial aspects of the model. And Nirav, I want to thank you and your team and for just providing untold hours of going through spreadsheets and swapping those spreadsheets back and forth. You've taught me quite a bit, and I'm personally appreciative of that. So that summarizes the timelines of, that summarizes the timeline of work today.
Thank you, Mr. Geisler. I'd like to call Councilman Kitchen and Ann Howard and Nirva Shaw to the table, please. Thank you all for joining us. Glad to have you here.
Thank you. We're glad to be here. I'm Ann Howard. I'm the Executive Director of ECHO, the Ending Community Homelessness Coalition. It's good to be back in this seat. I think, each year maybe we've done a little update on the project. And over the years that we've been working on this, and I appreciated the timeline, Mike, not only have we built relationships, but we've done a lot of work on homelessness in Austin. The city council's identified that as one of our top challenges. But here, in this very space, we've done a lot of work, as you guys have led the way in building the crisis response system that addresses mental health, that tries to get folks out of the jail, now looking at mental health care for children. I mean, lots of work on the stuff people need. And what we know from our work around homelessness is they need housing in addition to access to health care and job training and treatment, substance abuse treatment and whatnot. So I think right now is the perfect, even though it feels like it's taken way too long for this project to come to be, I think right now is the perfect time for our community to have the resources to house 250 of the most chronic homeless, 250 folks that are cycling in and out of jail and hospital. And I say that because of the way we're working together. The social service agencies work together better than before. We have a data system that identifies the clients to house. We have landlords offering leases to our clients. We've gotten the housing authorities, both housing authorities, the Travis County Housing Authority and the City Housing Authority, to do voucher set-asides for people who are experiencing homelessness. So we're teed up and ready to go and put this project into action. So I think the time is right. So I want to give you just a high-level reminder of how the project works. And then I've asked Councilmember Kitchen if she would skip all the celebration going on at City Hall and just be with us and talk with you guys, because we know she speaks the language of healthcare and healthcare finance that I'm still learning. So, this project recruits private donors, private investors, to put up their money to help us scale up permanent supportive housing. And then when a third-party evaluator says you hit the metrics that you agreed, only then is that money, is other money used to pay back those donors. Okay? So that first set of contribution, we're looking at investors or donors that include the St. David's Foundation, that include community foundations, that include community developed financial institutions. Those are who are, as Councilmember Kassar likes to call, the donors that you might be paying back if we hit all the metrics, or as we hit metrics that we've agreed. The service model is assertive community treatment. It's a SAMHSA-based approach that's designed for folks that are dealing with mental illness, substance abuse, and homelessness. It's right on target for these folks. This is a $16 million project. If you were to use the money you set aside with the Episcopal Health Foundation and the CCC, and now with the Seton gift, you would be spending about $3 million out of a $16 million project. So we're really leveraging lots of money to make this happen. And finally, the risk transfer. The whole model here is sort of designed to do something really good that our community needs to do, and at the same time have government understand what works. And so that's why your money is waiting to only make a payment on this project after we see if it works. And your payment would be proportional to the success. That's why it's called Pay for Success. I want to acknowledge up front, and I think Councilmember Kitchen will touch on this, we understand that the folks we're housing need health care. And some of that health care would be provided by your enterprise, by community care. Some might get health care from the new Oak Springs Clinic that the St. David's Foundation has invested heavily in. But yes, they're going to need health care. And so that has gone into the calculations that we've worked a lot with Mike on, is what is the cost of that added care for these clients. We have agreed that this target population will be at least 2/3 MAP or MAP eligible clients, because we understand that financially that's part of your commitment or your responsibility. And so we've been working together to identify the clients and to provide them with a set of services that we know will not only provide them a place to live, but also should show the reduction that we're hoping in access, in using criminal justice and expensive emergency medicine. So that's sort of how it's supposed to work. And the city council, after working with us for about 3 years on this project, has moved to a big fat yes. And we're glad you're here with us.
I go ahead.
Sure, sure.
Well, thank you all. Really appreciate the chance to come and talk to you today about this. I wanted to share the city's perspective, and just, I'm sure you're up to date, but I wanted to, we recently voted, and I wanted to share that. And also, this is something that's near and dear to my heart. I've been, of course, in healthcare for a long time, but working with the homeless issues has been a top priority for me also. So I wanted to say that the council, and you all may be aware of this, but the council, I think it was our last meeting, I forget, it was very recently.
The 28th, March
28th,
28th.
thank you. We unanimously approved this project. And by approved this project, we took 2 steps that were the next steps from previous steps that we had taken. We approved the first year funds, we committed to the 5 years of the project, and the total $6 million. So, and we did that for a couple of reasons. From the city's perspective, let me just say first off, from the city's perspective, we recognize that homelessness is an urgent issue and that we are way past, as a city, what we need to be doing in working with homeless individuals. I could tell you all kinds of stories in working with my district and with people all over the city. The community is waking up to this. So the council has made homelessness a #1 priority. But I can't overemphasize the urgency of us getting out there and doing what we can as a community. So the city council recognizes that. And this was the kind of opportunity that is a successful model, that is a collaborative model, because the other thing that we recognize as a city is we can't do it alone, nor should we. This is an all-hands-on-deck community issue. We've got folks, and I don't have to tell you guys, I mean, you know more than anybody, that we're dealing with healthcare issues, physical, mental health care issues, social determinants of health, housing, which is one of the key responsibilities that the city has. But we cannot continue to do this in the city paying for our portion, Central Health doing theirs, the county. What this model gives us, and what's so exciting to us at the city, is it's one model that brings us all together, both as payers and as looking for results. So I think that that is something that is very different and unique and is really important. This collaboration, working across our respective funding streams, across our respective responsibilities, is just, it was one of the most important reasons that the city stepped up to the plate. Because we need ways, formal ways in which we can do that put us into one project where we're putting our money together and we're seeing what results. I mean, we've already recognized in the healthcare community how intertwined social determinants of health are with mental health care and physical health care. And so we need to, as a community, think in terms of how our payer streams are working and how our responsibilities as agencies and community, people in the community are. So I just wanted to emphasize those 2 things in particular. We think that this also gives us another opportunity to try something that's pretty exciting, and that is the potential to partner with the private sector. We all know how limited funds are, and we're facing even more limits with what we understand is happening at the Capitol. we've got to be able to try models that help us partner with the private sector, and the private sector helps us put up more money fast up front. And I think that's really important. And you know, one of the things we dealt with as a city when we first started thinking about this was, well, why would we pay private investors for something like this? Why don't we just put up the money ourselves? And then we thought, well, what we're getting here is more dollars, faster, and we're putting together a bunch of partners, and it's worth it. It's very much worth it in terms of the investment that we're putting up. And it's tied to outcomes, which is critical because we have, you know, this is not a new issue by any means. Use of the emergency room, inpatient hospitalization, it's not a new issue. We've all been dealing with this for years, you know, decades, you know, in terms of how to better use our system. So, so I think the opportunity to do it in an innovative way like this is really something that we just couldn't pass up. The last thing I would say is I just am really excited about the potential to actually do something that could be lasting for these 250 individuals and for the system as a whole. We can use this to teach us how to work together. I mean, I know we work together right now, but I mean really in an integrated way, you know, in terms of how we work with our funding streams and things like that. And we'll learn things from it, I think, in terms of how we can be most effective. So, and it's a good time. The city's making a lot of investments in housing right now, and so we have made a conscious effort to make sure that our investments are targeted towards results, and then we do them in a way that looks at everything that's going on in the community. So anyway, so I really appreciate the chance to talk to y'all about that. I feel very passionate about this issue. I will say one last thing. I think as a community, we cannot continue to accept homelessness as okay. And I know you guys don't do that, but that's my message to the community when I talk to people. And the bottom line is we should be doing all this stuff yesterday. So.
Is that it?
That's it.
Okay, thank you. Mike, you can stay there because we're going to have questions
Sure.
right
Okay.
after Mike presents. If you could just outline for us the analysis that our staff does.
So members, in your packet, there is, you've seen the memo, it's a revised memo based on the email that was sent out earlier in March. And I'm happy to go over that and answer any questions, but really what I'd like to do is just pull some commentary from that memo to put things into perspective. Even though at this time I'm recommending that you don't do this, I'm going to say it's okay to set aside my recommendation. Boards do that all the time. They hear from staff, they hear from other parties, and they have to do what they believe is right. And you have to do that. And you know, this is not the Mike versus Ann show. This is about doing what you think is right for the community. Do this because you want to, do this because you can, do this because it does have some positives to it. There's nothing bad about it. Is it what we would have designed? Does it have an ideal financial model? No, not from my perspective. And I'm just speaking on behalf of myself at this point. And you have the authority. You can do this. And it is innovative. It is time for us to come together as a community and really examine deeply what is healthcare. Is it a doctor's visit with prescription, or is it something much bigger that can go upstream and deal with an issue to improve people's lives, not just get them through that particular doctor's visit? So I think there's a lot of reasons to do this. And I would say this, personally, if I had a private foundation, I would fund this. I would fund it for no other reason but to learn. I would also fund it without any expectation of anything coming back to me. It truly would be a donor situation, not a kind of hybrid derivative bond type investment. And so just to, you know, again, I want to address some issues of, is this inherently a bad thing? Is that what you're trying to say? And the answer is no, that's not what I'm trying to say. I would also say that with the recent infusion of funds from Ascension Seton and I appreciate you all giving us a heads up on that. I think that does change the equation. To put it into perspective, it knocks about $200,000 off a year. If Seton, and it has, I realize, and I talked to Seton yesterday, I don't think the details have been ironed out yet about how they would participate. But if they are a back-end investor, that shaves down what you would have to put in each year from $800,000 to about $600,000 a year, if there was a max payout. Obviously, if you don't hit the metrics, that payout is a lot less. So just to put that into perspective, if you're coming at this from, wow, can we afford it? The short answer is yes, we can afford it. But I also think, going back to what was admonished in March and February of 18, at least the operating instructions that I was under, was go and look at the terms of this. You all can decide from a political standpoint what needs to be done. But I think I've really focused on the charge that I was given, which is look at the financial model of this and the associated terms. And I want to be clear, because we are an upfront investor today and have been for many years in the care for homeless, not only in the form of physical medicine, but mental and behavioral health, as well as case management under the CCC. We've been doing that for years, and we welcome those people that want to come to the table and put skin in the game like what we've been doing. That's great. We're going to continue to do that. And through this project, it may look like, well, there's going to be a savings in the emergency department and the inpatient, but the reality is, even if we get the emergency department down, that doesn't necessarily translate into a savings in healthcare costs on the back end, because if we screen somebody and we catch cancer, we're not going to say to them, whoops, you're no longer a savings to us, we're not going to treat your cancer. Of course we're going to treat their cancer. We're going to do it aggressively, and we're going to keep them alive. We're going to do our best to keep them alive, and give them a good quality of life. So my point is that if you think that there is a guaranteed savings, and this is where Nirav and I we have different starting points on the data and different ending points and different assumptions that we work on. We just agree to disagree. There is a possibility that there will be real savings, and that some of that will be realized by Central Health. But there's also the distinct possibility that there will not be savings. And if there are some savings, they may not be realized by Central Health. So the point being, you're going to have to go back to the taxpayers to make sure that we have the money, because once we guarantee these investors, we have, the way the terms are set up right now, we have to be able to put up that money each year to be able to show that we can cover the payout to the investors. So it won't, I can't at this point guarantee that we'll have the savings, so hence we'll need additional revenue to make this investor payout. I'm also talking about this in a vacuum. It's as if we don't have other things that we are also doing out in the community. And the one thing that I've not gotten into yet that I would ask you just to think about briefly is we're not doing anything to prevent homelessness. And I realize that is a tall order. It's probably as ambitious a thing as what we've ever even talked about here, but I think that in working with our partners at Community Care, Integral Care, ECHO, I feel like there might be some things that we could do to prevent homelessness, and I think it begins with mental and behavioral health to address some of the core issues that cause homelessness to begin with. And I realize we're talking about for persons that are residing and coming of age here in Travis County, but that's the sort of thing that I think we've really got to get into in addition to doing this right here. If you all decide to do this, I don't just want to turn a blind eye to actually trying to keep people from being homeless. And I think, regardless of what you all decide to do tonight, we're going to work with whomever. If you say no, go continue to improve care and outcomes and actually start working on prevention with Community Care, Integral Care, and ECHO and others, that's what we'll do. If you tell us no, we want to fund this project, then that's what we'll do, and we'll work with them. And again, there's no, I don't think, absolute right or wrong answer in all of this. If you do decide to move forward, you have, what I would recommend is that you just simply set aside the funding for this fiscal year and then really turn this over to legal counsel, because it's no longer about, I feel like I've discharged my responsibilities, which is look at the term, look at the financial model, and provide comments. It's really just down to legally, do you have a document that you can sign or direct me to sign? It's really no longer about the way the model is designed financially, or the way the care teams are gonna implement, what's gonna be new that the care teams are gonna bring to the table. That's already been discussed. So it's just a funding and a legal issue at this point. The other is that this information, this is an informational item posted for this evening, and so you will need to come back and have an action item at a full board meeting to be able to make any funding decision or any further instructions to management. So members, that's commentary just based on the memo, and I'm happy to answer any questions.
Thank you, Mr. Geisler. All right. We now open the floor up for questions, and I recognize Ms. Oliver.
Thank you. First of all, I want to say thank you all for coming. Councilwoman Kitchen, thank you for your advocacy in this area, and thank you for doing what you do. And I want to start by saying, as somebody who experienced homelessness in her teenage years, this is an important issue to me. I'm not sure that this is the way I want to tackle it through this financing model, but it is an important issue to me. I don't want you to think that I'm wanting to set this up for failure, because I want to see y'all do something amazing in this area. But the last time you were here, you told me, Mr. Shaw, that Bank of America and Goldman Sachs were the private investors behind this at a 9 to 12% rate of return in the prospectus. What has changed?
That was an example of investors that have invested in other deals. So the sequence of all of these projects is that we have to get to the terms we call the payers before we go out and raise the investment capital. We have a group of about 6 impact investors or private donors that are at the table that are interested in this based on high-level terms, in terms of what are we trying to accomplish with the homeless population? What is the model that we're using? Who are the players at the table? In terms
Sir,
of
could you use the mic, please?
Yeah,
Sure.
sorry, we're having-
Actually, why don't you pull another mic?
Yeah, I think he needs a
Since
hand
there's
mic
3
or
of them.
something.
Yeah.
Do you want me to repeat all that?
Yes.
Okay, last time we were in this, the question was, what are types of investors that have been involved in other projects? And so the Goldman Sachs and the Bank of Americas, plus many other foundations, were examples of different types of impact investors in other Pay for Success projects. There's 26 Pay for Success projects in the country right now. 4 of them are specifically focused on raising capital to improve outcomes for individuals experiencing homelessness. So the sequence of all this is we get the terms with our payers, which sets what the proposition will be for potential private donors, and then we go out and raise the money. So we have not raised $16.3 million. We have gotten $4 million of commitment from the St. David's Foundation.
That won't be returned.
That won't be returned. It's a grant.
So who are the private investors who expect a return?
So we haven't finalized who they are, but the types of organizations that are part of our group that we're talking to are community development financial institutions, community foundations, and a health-focused organization are the types of organizations we're talking to.
You don't have a list of finalists that you could share with us?
No, I do not at this point, because again, we don't know what the terms of the project will be until all of the payers have decided that they agree to move forward with the terms.
We're very close to that. The city has approved, the
City-
county is, and the terms that we've put in front of you are the terms that we would take to it. So we've started talking to the groups that he's mentioned.
Are Bank of America and Goldman Sachs part of that group?
No, he just told you who they were. Community foundations, community development financial
I
institutions.
don't know what that means, so maybe you can tell us what that
It's
means.
a community development financial institution is a type of financial institution that was created to provide financing to low and moderate income neighborhoods. So People Fund in Austin is a community development financial, a CDFI, correct. It is a community development financial institution. There's Capital Impact Partners who also has offices in Austin, that's a CDFI. They provide financing to charter schools, they provide financing to FQHCs, they provide financing to grocery stores in food deserts. And so they are institutions established to provide financing to low to moderate income neighborhoods, is what they are.
I mean, I hope that y'all can see what I'm trying to get to the heart of, is that the partners that you're pursuing, depending on who they are, will have a very, very different,
Why is that?
why is that?
Yeah.
Well, I prefer not to partner with Bank of America and Goldman Sachs, quite frankly. I don't think that's a good investment for us to make. And when you were here last time, 9 to 12% rate of return, I don't think that's a prudent thing to do with taxpayer dollars, quite honestly. If we're collecting property tax dollars, which we do, we collect property tax dollars, which is how we fund everything here. and then turning around and paying Bank of America and Goldman Sachs 9 to 12% rate of return is not something that interests me. I got to be honest. So that's why I'm trying to get at transparency. I feel like there's a lack of transparency on what you're willing to share with me. And that makes me apprehensive in wanting to invest in this.
So-
If you were being fully transparent and saying, I'm going to lay it all out here for you, including the budget. I would love to see a detailed budget.
The detailed budget, ma'am, is on the slide deck. It's on page, give me 1 second. Slide 21 is the detailed budget. And we are, one, to be fully transparent, we are fully transparent. We don't have impact investors that have signed financing documents say they're going to give money. So I can't give you that information because we don't have it. We're talking to a group that are consisted of those type of organizations. So there's not information I can share. And then on the return piece, I understand that there is apprehension around providing a return to impact investors. This is not something new that we face in the Pay for Success realm. I think what's important to remember is that this is not a bond where they're guaranteed payments of 9 to 12%. There is a full range of returns. So you can lose 100% of your capital in this project if the outcomes are not warranted, right? And
I remember you detailing that last time.
Right,
That's
so-
highly unlikely.
it is highly unlikely, and as is the 9 to 12%. So there's a full spectrum of range of returns. We believe the likely range of returns is probably somewhere between -7% and +7%, is what we
When you were
believe.
here a year ago, and we talked about this, I said, is there a prospectus? And you said, yes, there is. And I said, what is the rate of return in the prospectus? And we can pull the testimony, because I remember the question very specifically, because I asked it. And you said 9 to 12%.
That is the maximum range of return that we've put forward. I apologize if I misspoke, but there is not a prospectus yet, because we have not finalized the terms of the project.
So I think there are some other questions that I have, like, in the realm of tracking ER visits and unnecessary ER visits, we're having to rely on the two major players in this town, which are Seton and St. David's, to willingly say, tell us what and who is in their ERs for what, unless that's going to be tracked by a social worker of some sort. So how are the metrics going to be tracked?
So we are collecting encounter data at both the ED level and inpatient through the ICC, which stands for the Integrated Community Collaborative. Care Collaborative, excuse me for getting that wrong. And that is our local health exchange, which is where we're capturing information on individuals to understand their eligibility. So in order to be eligible for the program, you need a minimum of encounters in ED and hospitalization historically over 18 months, and that's also going to be the health exchange is where we're going to get information on utilization patterns for individuals enrolled into the program.
Yeah, that's a great source of data, you know, is it, I don't know how y'all work. Did I-
Jump in.
We're not supposed to do that.
Jump
the
in.
council. So anyway, so Julie, I was the executive director of the
ICC.
ICC, and it is it's a great source of data, and it's a trusted source of data, and it's a great source of data to track, like in this case, pre and post, because what's interesting about it is you can tell pre and post intervention by individual, so you can really get down to whether the intervention is working, which is something that is important. A lot of times you cannot tell if an outcome is really working. So this allows you to do pre and post by individual that's enrolled in this. So it's a really good source of data.
So is the individual willingly giving up their health information? Because how is that HIPAA compliant?
Well, that happens automatically when they go to a hospital right now.
Well,
So
I mean, the hospital is entitled to that information, but external people aren't.
So
By patient
all of
data
our
level.
clients sign, we run a homeless management information system, which is one thing. It's
okay.
not, that's not HIPAA compliant, but we get each client to sign a release of information that allows us to use any of their information to help them get housing and services. And this particular project would have, I would assume, whatever layers of, permission we need them to get.
So I know you're still putting this together. What would be initial investors, how much money are they putting up?
So we're in total, we're getting $16.3 million, again, of which $4 million in grant funding from the St. David's Foundation, so that leaves a balance of $11.5 million.
And then at the end of this, what do you anticipate the partners, like City of Austin, Travis County, Central Health, and at Seton, what do you anticipate them returning, paying? I mean, there's got to be some sort of.
We
yeah.
have invested $6 million from the city because of the value that this project brings forward to us. So, so that's over time, you know, that's over the five years of the project. So, so it's, I think the city's the biggest investor in this. So yeah, but y'all, you're getting the slide.
So on the investor side, again, there's a full spectrum of negative 100% to positive 12%. Both of those ends are lower probability scenarios. What we think is a likely scenario, I don't have what that means in terms of nominal dollars, is negative 7% to positive 7% is the range we think based on what we've seen in terms of the outcomes to date historically here in Austin that we've done in permanent supportive housing over the last 4 or 5 years, and based on what we've seen in national models. So this slide here, I think, is a good example. So part of this risk return, and this is something that I have kind of Mayor Adler right here all the time, because he's talked about if we're doing this model, we better be shifting risk away from our payers and to our investors, because if not, all we're doing is some sort of financing.
Exactly.
Right.
That's
And
the concern I have.
So let me point you to this slide. So today, if you look back over the last few years, and you look at permanent supportive housing for this population, we've seen a 49% reduction in ED utilization in the same window that we're going to be measuring, and we actually seen an increase in inpatient days of 94%. So the way we've set up the model is that if we hit the same returns that we have historically at double the scale, because this project will double the scale on a monthly enrollment of permanent supportive housing, the investors will lose money. And so that, if you look at that bottom star all the way to the left, that is essentially an improvement on what we're doing today, because we're showing an inpatient reduction of 0, meaning no change, where right now we're at a positive 94% increase, and we're showing the same amount of ED utilization. Central Health, out of the $6 million of total healthcare payments, only 2.7 will be paid. So what that translates to for Central Health and CCC will be about 1.35 million on your $3 million payment. And so the only way to get up to $6 million, which is the maximum payment out of all healthcare, is we need to move the needle from increase of 94% on inpatient to a reduction in 15%. So we're moving the needle from an increase to a negative, and we're getting a slight improvement in ED reduction, is what you have to see in order to get that full $6 million payout. In addition to this, you need to have housing stability rates at about 85, 86% of the population has to stay housed for 12 to 18 months. And then you also need to see criminal justice reductions that are above and beyond what we've seen historically.
And we have to get them all housed.
And we have to get 250 people enrolled.
And what happens if people drop out or leave? Do you replace them with others?
We would replace them with others,
But
right?
their date starts over. You know, the housing stability, they have to stay housed for 6 months before it sort of triggers that we can count that they were successful. And then, you know, if they're out of their housing, we subtract the days. We've done a lot of work with the city staff to get that just right.
And so there's 2 risks that are not insignificant here. One is, can we achieve the outcomes? Healthcare, criminal justice, housing stability. The other big risk is, can we actually identify and enroll individuals? So we're working off a list of historically who are the highest utilizers of our ED and criminal justice. Based on that list, ECHO and the service providers have to go out and find individuals based on that list at double the pace that we've been doing now. In addition to that, we need to make sure that when we find the individual, there needs to be housing that we can find at that given time to put that person in, and there needs to be a housing voucher. None of that is incorporated into this model. That's getting paid for through different means. So that is not an easy task to go out and just say, okay, well, we have 250 people, let's go find them and find housing and find a voucher for them. So that's real risk.
Yeah. Until about a year ago, we were housing whoever sort of came to our door, right? But I think it was really what we learned with housing veterans, where we're just housing veterans. And now we've moved to we call it the by name list, you know, whether they're youth or this group of frequent users. We're trying to find specific individuals. And we do that by working with community health paramedics and police and other outreach workers. I was talking to the Healthcare Council group about how we could, flag people in the emergency rooms and if they're on our list that we're looking for. I mean, this is where I'm excited about this time, why I think we can be successful, because we've done so much work as a community to help find people and get them housed. But it is a new way of working for all of us, because you got to go find Jim Bob, and where is he? Is he under that bridge or that one,
And another point I'd add, just as a reference, and don't quote me on these numbers, but government issues debt all the time to private investors for repayment. I believe the debt on Travis County and the city is somewhere hovers between 3 to 5%. And that's,
reasonable.
but that's also guaranteed.
9 to 12 isn't it?
But that's also guaranteed,
I
right?
know, I get that, yeah.
Assuming that the city and Travis County don't go in default, you're going to get that irrespective of what happens.
Right.
Right? Where this is not guaranteed, that you have to perform better than we have historically in order to even get a positive, even get your dollar back. And so there's clearly a different level of risk related to the investment than, but for me, that serves at least as a helpful reference point.
Well, I guess, again, going back to my initial concerns at who the investors are. For me to buy into this, I want to know who they are. And I want to see what they do. I want to see what they do in their regular business. I get the grant, don't worry about the grant, you don't have to tell, I know who that is. And the grant is a grant, it's just given. That's wonderful.
And we are happy to share the names once we get finalization who the names are. We're just
But-
not there yet.
So the way I'm looking at it is if somebody's putting in $16 million collectively, $16 million, and you have people on the back end paying in $16 million, that $16 million is really going to the $11.5 million folks, because you said the $4 million isn't going to get repaid.
Potentially.
That's a lot of money that they're getting. That's a huge spread.
It's over a 5-year period. The
I get
maximum,
that, that's still a big spread.
the maximum.
And we could
pay-
provide a whole lot more services. And I know, Councilwoman Kitchen, you said, we've never been able to do this up front with our own money. And that's what I would advocate for. Let's just do it. Let's make that. Let's collectively, and I love that you're wanting to collaborate in this way. Let's do it.
Well, that would cost quite a bit more for each of us to put in what it would take to do this, and we'd need to do it now to get the kind of result that I'm asking, that we're all talking about.
Well, you're willing to
That's
put
the
in.
difference here. That's the difference here, and no offense, but you all are talking about $200,000 or $400,000. It would take quite a bit more, and you would still have the same kind of issues that, that Mike is raising. So it sounds like that's not, if I'm hearing you correctly, you're more concerned about a model that has the private investment side of it? Okay, well, I certainly understand that, and we had those questions too at the city. And what overrode that for us is a couple of things that have been talking about here. I mean, one of them is the risk factor that has already been discussed. But the other was the ability to get the funding up front at a level that we need. You can't just look at this one project in isolation, because everybody's doing a lot of other things. So we can all say, we meaning the city, and we could all say, well, let's just come up with the money ourselves, but we haven't. And that's because we have a lot of other things on our plate that have to be addressed. And so the ability to leverage dollars is really important. And that from the city's perspective, we want to see how it works.
I still think
So-
that a $16 million repaid to people who've made an $11.5 million investment, even over 5 years, is a very substantial return.
So the investors will get capped out at $14 million and have the ability, if we shoot the moon on the outcomes for our service providers who are doing the work, to get a piece of, to get some sort of bonus payment, essentially, is how we built that in. And we can talk about that if we want to take that off the table. That's a discussion that we're completely willing to have, but we wanted an element of the service providers to get some funding back.
Finished? Thank you, appreciate it. Well,
Thank you, Chair. Well, thank you, Councilmember Echo and Nova. Back in March 2018, I voted no. The reason why, and I'm glad to hear two words, and those were my reasoning: collaboration and sustainability. And that is the initial reason why I voted no. I wanted us not do the homelessness. I wanted a better collaboration with the county, with the city, with us to better serve and to serve more. And that was really the reasoning behind it. Now, when we're talking about homelessness, I believe it's a social justice issue and it's a health equity issue. And we, as I sit here on the board of Central Health and I walk in at every meeting and I see the homeless outside, I feel I'm a hypocrite at that moment that I cannot serve them. And is this a perfect project? No. Are we bearing the risk? No. And because we don't have the means, and I understand and I respect your recommendation, Mike, but I look into it and I believe housing is health and we can improve the overall health of our community. And it's not just reduction in ED visit. Think about the value of having a home to a diabetic patient. Think about a value of a patient who wants a sustainable workforce. And that you thought about ways to get them out of housing. And if they have a sustainable home, they can get a decent job, and that can lead them out of the need of us. And I understand the cost, and now giving in the perspective that Ascension CN is going to be a potential partner incentivizes me more to move forward with this. And I believe we've had these discussions back before I even sat on this board, back in 2016, with other partners to be part of this. Now, thinking on another level, Central Health's credibility with the other partners who already committed additional funding. And I have heard that this potential project may not succeed if we pull out of this funding. And a potential funder who is going to fund the health sector will not be able to move forward with this issue. And this has been done, a similar project at the University of Illinois through a project called the Better Health Through Housing. And they've shown that they could improve overall health for the chronically ill patients they've had. So overall, the data suggests that there's improvements. Now, what I would hope, that I know that you have mentioned the 2/3 of them are going to, of the population, the 250 are the chronically ill. I would like and hope if you can bump that up a little bit, and I know the scoring,
2/3 would be
The
MAP.
MAP, it's not chronically
Not
ill.
chronically ill, MAP.
Oh, those are the
They're all chronically homeless.
chronically
Chronically
homeless,
homeless.
but 2/3 or more
Would be
would
MAP.
be
MAP.
MAP or
MAP eligible
sliding
probably.
fee.
Right.
Yeah.
Okay. Well, overall, I think every homeless individual, regardless of what caused them, what brought them to be in their situation, we cannot govern it, but we here have an opportunity to provide and to change someone's life. And I would definitely recommend that we move forward with this. We don't know, I understand we have a lot of other commitments, but saving an individual, even if it's one, will have an impactful health for our community, for all. So think about the domino effect of one individual. And if clarifying that we're going forward with collaboration and an opportunity to have this program sustainable for those who are in need and hopefully potentially grow in it. And we're learning from this. And I understand CMS have done similar projects with Pay for Success, and it has been done. Yes, I want us to be good stewards to our tax dollars' money, and I think for them realizing that we are doing good for people and serving and knowing it's an urgent issue. We all here in the room have homes to go to, but how ethically is it for us to discharge a patient that I've seen to the streets. To me, that's ethically wrong. If I'm in a position of power, I would definitely recommend that we move forward with this item. Thank you.
Thank you, Manager Saito. I know we probably have other managers that have questions, am I correct? No?
I'm gonna hold my
You're gonna
thoughts
hold
for the
yours?
moment.
I have a question. On slide 5, you have the service providers, the outcome payers, and the private donors. And help me understand if, I'm just gonna pick a number. Say Central Health put up $1 million, okay? And that $1 million is set aside so that if the program makes the outcomes or achieves the outcomes that are stated, then that money, along with the other donors, pays the investors. Am I correct?
Yes, sir.
Okay. So the services that we're giving to the homeless throughout this time to make sure that those objectives happen, we're still paying for that.
For this, you're paying for community care, right?
Right.
And some healthcare things, but in this project, right here, the private money is being used to pay for the services. We'll have a nurse, a drug addiction counselor, a psychiatrist, a caseworker, someone who focuses on their staying housed, not violating their lease. And we've been working for the last 6 months with Integral Care and Caritas of Austin to scale up their permanent supportive housing programs to do that. And so the private money will help us hire those teams. It'll help ECHO go find all those clients and do the data matching and stuff. So all of that upfront work is done with the private money.
But the private, I don't see us as a service provider.
You're not.
Right. But we still provide services to those individuals.
Absolutely.
Okay.
But you're not part of this, the assertive community treatment is all about the team, the 10 people who are daily responsible for those clients that we've moved into housing. They might take them to your clinic, they might take them to a different clinic, they might take them to job training or an art class, the grocery store, whatever we need to do to keep those clients housed. So that's the assertive community treatment team, the ACT team. And that's what the money pays for over the 5 years.
So basically, oh, I'm sorry, did
No,
you finish?
yeah.
So one way to, perhaps, to think about it is, those could be those would be your patients regardless. They may not end up in your door because of, I think Mike may have touched on this. With a project like this, you may have more cost because these are people you would serve anyway, but they're not getting to you. But you want them to get to you, so I would set that aside. I mean, so there's that, but you're getting more for your money because when you serve someone in a clinic, and you're not in a position in that clinic to serve the whole person, then the effectiveness of the service that's provided in the clinic is really reduced. For example, you guys know this. I'm preaching to the choir. You know that if a doctor prescribes medication, that person may never get the medication. You know that, and you know that they may never come back.
That's true.
So this kind of support, it provides the support, and now your clinics provide support too. I know that the clinics have social workers and things like that, but this is a more holistic approach for that individual, dedicated to that individual. So that's what I would think that you would be getting in this kind of model. So
Thank you.
is that what
Mike?
Yeah.
I think if I could answer your question differently and just taking the chart that they have up here on the screen, there's another box that I would draw up to the top left, and it would be service payors. Because right now, we're listed as an outcome payer, and under this model, that's correct. But again, what's missing is the recognition that Central Health, as well as its partnership with Ascension Seton through the CCC, are paying for care now. And we pay for care in two ways. We pay for it through the IGT that we send up to bring down federal matching funds, and then again, through our partnership with Ascension Seton, we pay for specialty and primary care and behavioral health care, because that's where all the contracts sit. So there's really another box, I think, that would be attached to that. That's not my slide, it's their slide, but if I would drop that in there, because then I think it would give us a fuller picture of how we would fit into that.
Mike, you're not paying for everything that these patients are getting.
No,
So.
That's correct.
we're just paying,
We
The medical
IGT,
part.
we bring in federal funds.
Right.
Yeah, but I mean, you're not
Bring
even
up a good
paying for the
point, but-
full, you're not even paying for what they fully need to take advantage of the medical care, that's what I mean. So, because of the example we just talked about.
I'm sorry,
the wraparound services is what you're
Yeah,
saying.
because of the
So,
example we just talked about, it's so integral. You know, it's just like if they're on the streets and you give them medical care, they're not really gonna be able to take advantage of it. But it's because it's the whole social determinants of health. They're so intertwined. If all of these services aren't provided, then the medical care that you may be paying for is not, you may be losing money in a way that you're paying for something that's not effective. So, I mean,
Yes,
we
ma'am.
see
And
that all the time from the city side.
I understand what you're saying, and that's why in my earlier remarks I pointed out that there is a lot more that we could be doing with our partners for community care and integral care, especially as they come together to provide more coordinated care. And so I don't disagree with what you're saying, although I don't think it's as stark maybe as what's being represented. There are a lot of people that are out there on street teams and in integral
Well,
care,
sure,
and
but
community
they're-
care, and other clinic providers that are really out there.
And they
their heart
really
and
want the
soul.
clients to get housing,
really
you know,
putting
and
their
that,
heart and
yeah.
soul into this.
Well, of course they
And-
are, and we know them, Mike, but they cannot be as effective as they could be if they're having to search for the person, if the person is having to, you know, it's the housing part. If they're having to search for the person, if the person is, I mean, they can't take full advantage
Right.
of those services.
Right, and I don't disagree with that, but
Let's see if they have another question.
go ahead, no. Then, in some ways, and please correct me if I'm wrong, as you said, we would continue to pay for probably services that individuals would be receiving
Sure.
anyway. Let's just take that as a given. And their medical services.
Right.
But this money that's over in the outcome box would be repaid to the private donors. So indirectly, we're actually paying for those wraparound services that you're talking about
If they're
that
successful.
achieve the outcome.
Yeah, if they're successful, you're paying for them if they're successful. But you're paying for the portion that relates to healthcare.
Right,
Right.
they're doing that.
And the 3 million would equate to about paying for 20% of the cost because of the leverage factor of everyone else coming in.
Yeah, so you're leveraging, the city's leveraging dollars by working with you guys.
Right.
You would be leveraging dollars by working with the city. And again, it's all based on getting the kind of results that we need to see happen for this to be permanent.
All right. Those are my questions. Manager Jones?
I have a few comments and then a couple of questions. First of all, thanks so very much for coming here. I really appreciate, for the first time, being a new member, to get a picture of what we're outlining here. Second of all, I guess my question is, I don't understand how what you're asking is not unlike what we're doing now. We're currently a leverager of resources to providers to receive outcomes. And so I have some concerns with people saying this is sort of different for us to do. That's what we do. We don't provide services. And as a result,
We pay for them.
we end up paying for them. As I understand, you're asking us to support a model for a population that is 100% within our target population. In fact, this population is probably among the most targeted. So I've had some, I understand the model is unique and different. That I get. And I think that my concern with that is that the questions that my member has made earlier, I think you addressed those for me. I'd be interested in how the city views those concerns, because they also have the same issues and outcomes that we as board members would have. So could you speak a little bit to the concerns of those investments from the city side particularly?
You mean the concerns that, that Julie raised, those?
Yes.
Okay. Well, I think, I think it's it's the element of risk that's the factor that's different than if we were just financing it. And so, as you mentioned earlier, so that's one of the things from the city's perspective. It lets us leverage dollars in a way that we might not be able to leverage otherwise. And it's something that the city needs to try, you know, in terms of leveraging dollars. We've got to have access to more available revenue out there. So that's part of it that is intriguing. The other thing is that that it's based on something real, you know, in terms of what we would get for it, and that's the outcomes. Because the outcomes are something that that have the promise of being more permanent, both for those individuals and also from learning a model that could be sustainable. So that all of those things makes it worth it for the city, and also the ability to leverage those dollars right now because of the urgent need. So it's all those factors together that make it something that we felt like we needed to try.
And unlike the healthcare district, you're also a service provider, and in this case,
That's
of
right.
financing.
That's right.
Our sole purpose is financing. Now, whether we like it or not, that's a model that we have gotten into. So I guess the fact that we have a model that will assure us of outcomes without, or else then someone else pays for it, seems to me to be an ideal concept. As stewards of the taxpayers' dollars, rarely do we get people to come talk to us about, we can guarantee you this if you invest in it. If not, then we take the burden. We're already talking about how we're going to have to address the gap that we might see based upon what happens at the Capitol. And here we have a model that be able to give us, in a small part of what we do, those kinds of assurances with some risk, but that's what we do anyway. We invest in businesses and providers that we can't guarantee that the results that we're going to get from them are going to be successful. Not in terms of money, but in terms of outcomes of product. So I think that this is a good opportunity at the right time to be able to support this as a pilot to see if it works. Obviously, if it doesn't work, we can reconsider it. But we have to, as a financing district, and I want to emphasize financing district, not a service district. We have to look at other models by which we're going to be able to provide services for our community. So I would encourage us to consider moving this forward.
Thank you. Appreciate it. Any other comments?
Then I'd like to speak.
Okay.
Thank y'all for being here. And homelessness is an issue that's near and dear to my heart. I have friends, family members, really close friends who I go help them look for their children and their family members on the streets on a regular basis. And some of them are right here. I know where they live when they're in the streets and using. So I support anything that can be done by the city and the county to address the homelessness issue. I think one of the concerns that I had previously was how much money ECHO has received historically from the city and the county and anybody else to address the issue of homelessness. and how successful have you been in decreasing those numbers? That was something that I wanted to see because it would show to me that you have had success in addressing the issue of homelessness. That's an issue also that goes to the heart of what the city and the county are supposed to be providing, and that is housing for those that don't have it. And I know the issues that are part of the failure to support increase in construction for affordable housing units with the great needs that are increasing almost every year and exponentially. And yet we have not provided enough housing for the people that have been waiting on the list for years. Okay, and that still hasn't changed. Okay, and with respect to that, those are issues that I know all about. Using the terms social determinants of health, it's social determinants of one's quality of life. And so of that, about 15% of that has to do with healthcare, access to healthcare, and failure to receive resources when they're needed. The rest of it has to do with no housing, no job, no grocery stores and pharmacies and doctor's offices and clinics and et cetera, in a neighborhood where our people of poverty live. No transportation. All these things are controlled by the cities and by the counties, not by us as Central Health. And one of the things that I was asking for and have asked for is that the collaboration that occurs with those entities to come up with a comprehensive plan that would specifically address housing, failure to provide appropriate and affordable services for the needs of our population, our residents, all the residents actually, that have those needs. And we're here to support you in any need to provide those medical services, those pharmaceuticals, and everything else that will increase especially those living under 200% FPL. And of course, more than anything, the homeless access to those resources. And that's not even a question. That's something we would do. You're talking about 250 people. 250 people. And those 250 people, if we were to have given them 16.5 million, I guess, they'd $66,000 a person on top of the MAP services that we would be giving them anyway. And we do have pop-up teams that go looking for them. And we do have providers that we give money to so that they can provide services, case management, to make sure that they access their doctor's appointments. We have community health workers that have been hired specifically to serve as the liaison between them and their appointments and their medical home and their needs to incorporate behavioral changes so that they can really look at curbing and stopping whatever is keeping them on the streets, either by choice or by horrible circumstance. And each of us support that 1,000%. So with respect to your ask, though, in light of the fact that we have these great needs in our community, in Travis County, in the city of Austin, and I never got an answer with respect to the amounts of money that have been received by ECHO for addressing the homelessness problem. The city of Austin, how much money have you all invested in homelessness? The county, how much money have you invested in homelessness? What results, what outcomes have you gotten? How have you decreased that number by the amounts of millions of dollars that you've invested? I don't recall having received any information with respect to that. And so I appreciate your great endeavor in helping to put something different before us so that we can consider it. But, the Pay for Success program, like as you said, sir, is in 26 other communities. I don't know how they're going. I'm assuming they're successful because they're still in existence and they're still running. So I appreciate that. But when I look for Central Health's contribution to this project, I'm looking in terms first of how are we working to comprehensively and collaboratively as governmental entities, because we're a governmental entity also. You're funded by governmental entities and by private foundations. But you're here with the city of Austin. We have county commissioners, we're Central Health. And together, how have we put together the plan? I guess it's, I want you to understand where I'm coming from. Where is that comprehensive plan that I know we should, if it hasn't been done, we should be doing it. I have asked that we do that, because as we do that, we take responsibility for certain things within the spectrum of what is considered social determinants of our quality of life. And, okay, you're going to do this, you're going to do this, you're going to do this, and we're going to contribute this. And gladly so, if I personally, and I don't know, maybe some of the other people that I've spoken with, can see that we're actually making a commitment to do this, and we're doing it.
You want me to
But-
answer your question?
Yeah, go ahead. You want to go ahead and answer before I finish? Or you want to go ahead and answer? Or say something, respond?
I don't know that there's a question. What
Well,
was your specific question?
Well, I asked initially, where is that money? And
The money
what has
that
been,
is received by ECHO? Is that
yes.
Okay.
Where has that money come from? And to accomplish what? Were there metrics involved? Were there outcomes involved? Because as you regularly give money, and you keep giving money, and you show me that we still have about a 3,000 to 2,500 to 3,500 homeless population,
Okay.
and the number doesn't seem to change much,
Right,
okay?
that's
You know,
That's the question.
That's the question.
that's one question, but it's still,
We'll
there's,
get
I
your
appreciate
other
it.
question.
I appreciate that.
Sure, go ahead.
So we did put together a community plan. It's called the Austin Action Plan to End Homelessness. I think I shared that with you, and we talked about getting together, but we haven't
No.
to go over that. The city council actually endorsed the plan, took it up and reviewed it. Sarah Cook is one of the advisors to our monthly meeting, the membership council. We have city staff from Austin Public Health and from Neighborhood Housing. Council members' kitchen staff often attends. Mayor Kathy Tovo often attends, and her staff. The new interim homeless coordinator for the city has attended her first meeting.
I'm thinking
Travis
of
County-
numbers, and over what period of time?
Okay, well, I was telling you about the plan.
Okay,
So,
no.
but that action plan addresses outreach and shelter, it addresses housing and services, it
Mm-hmm.
addresses community collaboration and the effective use of data, and the
That's right.
public-private partnership needed to actually fund the strategies. This project is part of the plan as an element of that public-private partnership. It addresses healthcare in there, and healthcare for the homeless is something Central Health and the CCC have been working more closely with us on. As far as funding and success, I'm not going to cry. I wish we'd had a lot more success. But after 8 years, we're sort of at a steady state. If you look at, the number in shelter, we have about 1,000 shelter beds across this community, and every night, most of them are full, so that doesn't really change. We're looking at adding shelter. The number of homeless measured in January had increased by 108 people over the 1,000 square miles of Travis County. That's a 5% increase. 1% increase is too much for me.
I agree.
Right? And so why are we seeing an increase in homelessness? We look at affordable, what's affordable in Austin? We look at access. We've done tremendous work with justice, with criminal justice, with advocates from the law school. We've published as a community a document, I call it Locked Out, but it's really looking at rental housing and what is the ability of somebody who has a criminal history to rent housing? What is the ability to get a job? And so we're sitting here as the little homeless workers really dealing with healthcare, criminal justice, education, housing, job, it goes on and on,
No,
right?
I know.
And so we did put together, lots of people wanted a plan. Right now, our homework for Councilmember Kitchen is a work plan. How do you take that plan that's identified the strategies and the cost and put it into actionable items? And that's, what we're working on right now. And so, as far as money, ECHO is paid mostly by the federal government, and our biggest local contributor is the St. David's Foundation. We've been fortunate that every time we hit some success, we win another grant, if you will. This project alone, because of all of us coming together, I was thinking about, the work Clark Heydrich did on this grant, or the work that Trish did, or Christy Garby. Central Health has looked at 3 different projects using Pay for Success. One was about teen pregnancy, one was about nurse-family partnership, and those were in conjunction with Austin Public Health and the United Way, the Michael and Susan Dell Foundation. I mean, this community has looked at this funding model, and this is the project in Texas that has stuck. So,
I'm sorry, I think I missed out on the number
okay.
of
and-
dollars that have been, that you've received
So my budget from the city of Austin is about 300.
over 8 years that you've been doing this?
Over 8 years?
Yes.
I don't know each amount each year.
Well,
I mean,
that's what I was referring to.
Okay.
And I know that in any one person increase, not 1%, 1 person increase
Absolutely, that's what I meant.
is too much. I agree with you
Right.
100% on that. But what I'm trying to gauge is success. Or
Could I-
change, effective change in,
We were
in
declared
what,
an
the strategies and
Okay,
what's
could I-
happening.
could I-
Veterans Youth.
I just,
Could I speak to that?
yes,
I
please.
would
I
love-
appreciate that,
I
Councilmember.
would love to sit down and, because I don't want to take y'all's time to go
Yeah.
through everything, but let me just hit 1 or 2 high points, and I'd
Yes.
love to sit down, because I know you're really passionate about this area. So, the city invests about $30 million a year, and that's just in social services.
Right.
You know.
I know those, I know the
You know
contracts
that we just passed a $250 million bond for housing.
for
which-
affordable housing.
Which will include permanent supportive housing.
Right.
We passed a resolution in January to create an additional immediate shelter, recognizing, I think as you mentioned a minute ago, recognizing the fact that there's no place for people to go.
That's right,
And so,
except out of town.
right, and so, so that's just 3 high points. We've also funded a homeless strategy officer who's responsible for an implementation plan. We have our housing blueprint, which is an actual implementation plan with timelines, et cetera. Anyway, I would love to sit down and talk with you more. What I'm hearing from you is the same thing that I hear from the neighbors that I work with, and that is, what's happening? It looks like it's worse. And it doesn't look like, we're all just doing this stuff, and it looks like to our community
We're
that
swimming.
nothing's happening. And so, yeah, and
Standing
so
still.
I share that frustration, and I think that, we have to get targeted on results, and we need to see in front of us all the pieces, because no one piece can do everything.
That's right.
I mean, there's no way in the world that ECHO can solve this
That's
issue.
right.
There's no way in the world that the city can solve this issue. This is a community-wide thing.
That's right.
And we need a plan with an implementation plan, and everybody's playing their part. So let's have a longer
Councilmember-
conversation about that.
Councilmember, that's specifically what I have asked for, almost using those exact words.
Well,
And
I'll be
and you
happy to
didn't hear
share.
me before, that's almost exactly what I have said before.
Okay,
And,
great.
and so, with respect to that, and with respect to this ask, I have been curious as to what the real ask is of us, because we originally were thrown a number of 1.2 million. I didn't know if that was a cumulative amount, if it was just this first year amount, because I know the project is 5 years. The project length is.
He can answer that question.
I'm sorry, I didn't want to interrupt, but I can respond to the
Please,
question.
please.
So originally, $1.2 million was the ask, and at the time, because of the way this was all happening in very rapid fashion. And I think that we were wanting to get this in front of the board because you all were trying to secure commitments for FY18. And that you needed something on the books of people's budgets, if I remember correctly. Because you were trying to go out to potential funders to say, hey, we're pulling this program again. Correct me if I'm wrong historically. This was how sophisticated the calculation was to get to 400,000. We simply took 1.2 million and divided it
By
in
5.
thirds.
So, okay.
And because we realized there was so much that we hadn't done yet. We hadn't looked at the investor pro formas. We haven't, and I appreciate the more detailed project budget. I think it's informative. We hadn't looked at anything. So the question was, okay, what amount of money could we stomach just for the sake of participation and keeping the dialogue going? And we arrived at the figure of 400,000 for the central health and 400,000 through the CCC respectively for a total of 800.
So, so with respect to Central Health and our commitment to helping to address the needs of our most vulnerable population, that's all of them. And surely, even those individuals that are homeless, that are walking the streets receiving Social Security checks, you know. So, I mean, I understand all that too. But, that my perspective, maybe it's not one that's shared by others that are in this room, but I will tell you that my 100% commitment is to our MAP population, to our those are eligible for MAP that are not yet on it, that are on MAP and expanding their services, that are not citizens, that don't have legal status, that are eligible for even less. Because their qualifications are different. And so personally, I'm first and foremost for expanding services and eligibility to our MAP under less than 200% FPL. That's my first priority. And I wouldn't have if any of those 250 people that you're targeting are chronically ill, then I say we're going to put them in the CHAP program under Sendero and give them a whole, pay for their premiums, and they're going to get access to a continuum of care under a health insurance policy. I would say that, but I would also say that I have to recognize that as the city and as the county and as everybody else is going to be struggling for dollars, like we know we are going to be, because we're juggling a lot of things, a lot of issues that are coming at us almost all at the same time. I initially was very hesitant. I think I outright said no. Now I may still be there. I'm going to have to think about this for a week, okay? But I want you all to understand, and I want the public to understand, that in light of what is happening to Central Health and to our ability to expend dollars to our targeted population, it has been very difficult for me to look at anything outside what our commitments are right now. And as I look at still fighting for MAP to get extended to more than 6 months, because as we all know, if you have to reapply every 6 months, there's a great possibility that a lot of people are going to get dropped from the rolls. And so, when are we going to incorporate the change to 12 months? That's a cost, that's a okay. I'm sorry, Holly, thank you. So as we look at those potential costs for what I thought we should have already done years ago, and we're still waiting to do that, I have to weigh the urgent, because those are urgent needs that include the homeless population, for expanding and including them in our roles, and understanding the implications of a possible legislative cap on our property tax rates, and understanding that how we're going to fund the services that we receive.
If I may interrupt you.
I'm sorry,
okay.
okay.
I've got to take a phone call from the medical exchange, so I don't have any questions, Dr. Chairman. my vote stands as it was from last year. So I agree with Manager Musaitif and Manager Jones to proceed this to our Board of Managers meeting.
Okay.
Maybe not this month, but maybe next, because I'm not gonna be here this month.
Oh, yeah.
So with that, I gotta take a phone call.
Sure.
I'll be right back.
All right.
I apologize.
Manager Greenberg, I'll
Yes,
get back
thank
to
you.
you,
Thank
and so you can wrap up, Cynthia.
I will, I'll
Yeah.
wrap
Manager
up.
Greenberg.
First of all, I want to thank everyone who has put so much time into this over so many years, and that would be
That's right.
our staff, the city, council members, staff there, and her staff, social finance, people in this room, and people who I don't even know of. So thank you, thank you, thank you.
Everybody.
Beyond that, I think that this is an issue that, as we have all noted, is of the utmost importance to our community. There's no denying that. And I can't help but think about numbers. And when Ann Howard, when you said that in fact the numbers have increased, also I know that the population here in the city of Austin has been rapidly increasing. So as that, I don't have all the data in front of me, you know, I'm data driven, but I have to make, you know, I would have to see the numbers, but it occurs to me that as our population here has been growing exponentially, you would expect that there's a certain percentage of homeless increase, unfortunately, you would find, and that may have increased even more due to the rising costs of housing here. So I note that tonight, that came out in the conversation. I also note that I think there were some new analysis that came out in the conversation before us tonight, and some new facts. For instance, that the private donors would be foundations, CDFIs, and can you define a health-focused organization? I didn't see that defined on the slide.
So, we're not at privy to share the names of the folks.
I understand.
we're
No,
talking
I
to.
don't say who
So
they are, just what,
If I shared more.
is that a cat, is it a dog, what kind of entity, you know?
What does
Do we
it
have
look
any-
like?
What is it?
And if I may,
Yes.
one of the things in the actual agreement that we were presented forbids Payer LLC, which is a subsidiary of Social Finance, from sharing information with us about the investors.
Okay, so that's fine, I understand that. I was just seeking a little more clarity, but I understand that what you gave previously were examples, and those are not the names you're bringing before us now. You know, you're talking about foundations, CDFIs, and health-focused organizations. So that, to me, was some new information tonight. Beyond that, we have done pilots before with DSRIP, and we are a financing organization. Having said that, we have to look at all of our needs. But there was something really compelling that came out to me tonight. Certainly, leverage is important, being able to leverage those dollars and get more money up front. But the compelling point that I want to not just highlight, but thank you, highlight and spend some more time considering that I think came out to me tonight is this issue of, are we providing health care to people that we think we're providing health care to people, but we're not really getting outcomes because they're on the streets and they can't get medication and they can't get healthy. And so is this a way for us to better leverage what we're already doing for those people and provide them actually outcomes where they will get healthy versus a situation where they come into a clinic and they leave with a prescription that they never fill and they never get better. And so I think that that's a really important aspect that I heard tonight to consider. So I would just like to thank everybody for their input tonight. I think it was invaluable and I appreciate it.
Thank you. Appreciate it, Manager Greenberg. Ms. Valinez, do you want to wrap up anything, question-wise?
Well, I appreciate the additional information. I hope that we can have the conversation and that we can, if I do have other questions, but I would appreciate at least having the conversation with both of you between now and then, or whenever we have our final vote before the board. And I just want to say that I applaud your efforts for trying to come up with something different to address the issue so that you can move forward and maybe implementing a different strategy that we as governmental entities look at incorporating. But I have to tell you that I hope that the information I receive from y'all is going to be compelling enough for me to reconsider the comments that I made at the previous board meetings. And I just also understand and want you all to know that the people that I have lived with and supported in this community for decades are the people that have been displaced through gentrification and through policies that have been put in place by the city and the county. And aside from that, the resulting homelessness in my population and in my poverty population and the population of people of color has been, and to families and children, has been very, very disheartening to accept. And so as I look at where we are today and where we're going, without seeing real changes, I know that they're coming, and I know that they will happen, based on the actions that have been taken. At least so, I'm pleased by what the city's doing. I really have to ask us that we consider whether or not we are or are not providing those services, because as I hear presentations made to us from our own partners and providers, and that have come before us, and they tell us that they're providing case management, they tell us that they're providing wraparound services, they tell us that that we can't put a dollar on the amount of wraparound services that they're getting as we look at holistic holistic services for the patient. I hear that. We have heard that time and time again. And then to hear that right now we're not really providing that, but y'all are going to provide that, I'm just curious as to what exactly are we providing then at Central Health? Because if it's not what is being asked for, then I think that's something for us to consider. However, I would ask, why aren't we?
Okay.
And
Appreciate
why
that.
haven't we? Okay?
Appreciate that. Thank you. Ms. Musaidu?
Well, thank you. I just want to thank Mike, Mr. Giesland, for all the work and effort that you have done and put into this. Your staff, I see Community Care Collaborative, Dr. Hernandez, John Morgan, Sarah Cook. I know that your heart is in the right place, and I appreciate you being very efficient with our tax dollars, money. And I am also proud of all the work that you are already doing for our homeless community, and I want that to be highlighted, that we are already doing that, and we want to do more. And I'm proud to be part of an organization that thinks of the person as that we're serving from a humanity perspective, and we're compassionate to serve those who need care. I just want to thank you, and I want to also make sure that thank you, Ann, and your team, and thank you, council member, and I hope that we can see more presence of the city at our meetings, and I encourage hopefully more collaboration to better serve health, as we all addressed here, that we understand the social determinants of health that impacts different varieties and different pockets. And I hope that we can leverage the resources that you have to better serve our community. And I'm going to end it with the quote that Einstein always has said, that not everything that counts can be counted, and not everything that can be counted counts. To really think about that in perspective. Thank you.
I've got two other board members that have some comments and questions, but I'd like to ask a question. If you could go to your slide 15, I think. Is that the budget slide? 21. Those transactional costs that are outlined there, who's paying those?
The private donors will be funding all of those, and so they'd only be repaid to the extent that outcomes are achieved. So that's coming in from the private donors. They're
Can you
funding all
speak
that.
up and speak into the microphone
The
for the
private
record?
donors are providing all the upfront money, including all the transaction management
Just for
costs.
those who are listening, define private donors, please.
Sure, they're the impact investors. So
And that-
the CDFIs, the community foundations.
Thank
the
you,
health
because we have
funds.
people listening, it might not be clear to them.
Yep.
Thank you.
Mike?
Yes, but the other part of the answer, though, even though the private donors are putting the money up, if we do hit those metrics, they're going to be paid back.
Correct.
So
Bye.
that will come
Yes.
from the health payers.
Right.
Correct.
And
Right.
Yes.
So, and I'm-
Some of it.
Mr. Chairman,
Sure.
may I ask some questions because if you look up their social finance transaction costs at 200,000, and then their email communication and that we had earlier today, I also understand that social finance will be paid the 750,000.
Just the 750. The $200,000 is Corporation for Supportive Housing. They are a
Okay.
national nonprofit that helps communities scale permanent supportive housing.
So on the financial and project management fee of 750,000, so typically when you have an investor and you're serving as an aggregator of funds, there is an investment management fee that's paid, and typically that's based on assets under management, and then there are transactional fees that are paid either as a percentage of the transaction or sometimes flat fee. Again, it spans the spectrum, but are there any of the donors that are paying those upfront investment fees in addition to what is being paid here? Because typically, it's the investors that pay the investment fees, not the other way around.
This is the only fees that social finance is collecting as part of this project. And so the investors.
$700,000.
Yes, and I should be clear, there have been some grants that we've gotten that has helped fund our time over the last 3.5 years.
So part of the 3.1 million in transaction costs to be able to get the 13 million are investment management fees.
I would not call them investment management fees, but the 1.25 is the transaction cost related to this project. So if everyone funded this on their own, you would take out the $1.25 million. I think there's still a question of would you need other resources to help manage this, like the Corporation Supportive Housing. The work that social finance does after the project is launched, and we've done this in every single project that we launch, is we work with all the entities to think about how can we use real-time operations data to make sure that we are doing the best that we can to achieve the outcomes. And so that's the work that we're doing from years 1 through 5. We're also managing the governance of the project. We also move all the money around between the different folks. So we're managing those 3 elements is what that fee is for.
Thank you, Mr. Chairman.
And I would also just acknowledge that there's $4 million in grants that's helping offset some of those costs that
Manager Oliver, please.
Okay, so I went to the budget page because I hadn't reviewed this before I came, and there are a few things that stick out. One of them is at $750,000, which if it is an asset management fee, it's considerably high. It's 4.7% of the 16 million. And that is a really high management fee. I just have to say, from the work that I do presently and what I've done in a previous career, that is a high fee. Secondly, $200,000 says it goes to social finance. It doesn't say it goes to the CSH. It says $21,000 to CSH. So why is social finance getting nearly $1 million out of this project?
Yeah, sorry, I forgot to look at the year 0 line item, which is different. So we've been working on this project for 3.5 years to put together the terms. We're going to go out and raise the capital. We've helped secure $4 million from St. David's Foundation. I should also note we're a nonprofit. We're not a broker-dealer, and so we don't get a management fee or an asset, whatever term.
Well, you're getting some return here of $150,000 a year.
We are getting $150,000 a year, and that's our work ensuring that so I'll use a real-time example. In South Carolina, we put together a project that put together $30 million for the Nurse Family Partnership Project, which we groups. What we're doing is working with the Medicaid office, with the 9 different providers that are implementing this to understand what are the steps that need to happen in order to A, enroll people, and B, ensure that they're getting outcomes. And so that's where we're data dashboards we're putting together. We're convening groups on a bi-weekly basis to understand what's happening operationally, what are the areas of progress that we want to replicate, what are the areas of challenges that we want to fill gaps in. And that's the work that we do.
Is social finance investing in this?
No, we don't have we're a nonprofit. We don't have a balance sheet that will allow us to invest in this.
Why is ECHO getting $150,000?
Our job is to find the housing and to work with the landlords and we're bringing the social service providers to the table. We've been working with Integral Care and Caritas on a weekly basis to, help them understand the model, to work through how they're going to do this work. This is a game changer for this community on how services are being provided to a better place of how we need them to be provided to help people stay housed.
So I also heard two things. I think I have 3 final questions. One, where are the bonuses? You talked about the bonuses. I don't see them in the budget.
This is the budget that's going to pay for the services and the other costs associated with the project. The bonuses are going to come from the $15.5 million that's potentially repaid if outcomes are achieved.
Where is that gonna, which line item would that hit? Who's that going to?
There's a potential, so if we get above, so if you go back,
Yeah, I remember the slide, I remember.
okay, remember that slide, if we get outcomes even beyond that $6 million, there's an opportunity for Caritas, Integral Care, ECHO, and Social Finance and CSH to get a bonus.
How much is that bonus?
That bonus, I think it's about $250 for each organization. Is that right? Yeah.
And we
So in total-
sort of kept that as a buffer, not
Another
knowing
million.
where this project was going. We've kept that money there knowing that we might need it to replace the the central health money if central health doesn't participate. We've also known that we could take that off the table. Lots of the projects, right, like, I can't convey the work that goes into these projects for the group like Caritas and Integral Care to try to keep clients housed. And so if they could, get that money to do more work, it would be fantastic, but that could come off the table.
So, one of the arguments that was made was that by having this private investment, you're gonna leverage dollars, we don't have to put up money till later. I don't see a tremendous amount of leverage because I'm looking year by year and I don't see an initial infusion of $16 million or $15 million of cash. It looks like it's pretty spread out fairly evenly, and y'all would be collecting fairly evenly from us because y'all would be budgeting by year, we would be budgeting by year. So I'm not seeing the leverage of the dollars.
We're not paying anything, we're just putting the money aside.
And all the investors
So
are.
when does it get paid?
If the outcomes
If there's
are
If the outcomes are
At
achieved.
the
end
outcomes
of
are
5
achieved.
years, right?
At the end of 5
At the
years?
very end.
No,
sorry.
I'm sorry,
I can
there's
explain that.
mid-things.
No.
So
That's what I'm saying.
No,
I'm not
as
seeing
the
a
outcomes
tremendous
are
amount of leverage. I'm not sure that this particular project warrants the leverage that I'm hearing we're getting.
The leverage is that the investors are committing all $16 million upfront.
Upfront.
They're committing the full amount. So it's not paid out upfront, but they're committing the funding upfront. So that's the leverage that's
So
being
are,
spoken of.
we are as well, if we
No,
agree to this.
You're
and
committing
y'all
on
are-
an annual basis. So we're asking for
But
$200,000.
they're not, again, they're not putting in that money on the, like, they're not putting in that money at year zero.
They're not putting in
They're
all
just
the
committing
money.
to it. We're also committing to it.
I think Mike wants to
There's
interject.
we included your slide in the packet, it's on page 44, but it was the more refined scenario slide.
Yep.
If we can get the, and if you could take us to 44, somebody that has, take us back to, I'll take it, stop, keep going, keep going.
It's our page 44, I don't know what
Yes,
the
our
slide
page
number is.
44, keep going. Right there. So, if you're willing
Yeah,
to read
tiny.
vertically.
Oh, yeah.
Yeah, yeah. I think I'll read it on the page, thank you. Or
If you'll
do a
flip to
handstand.
that page in your book, and
Yeah.
turn it sideways.
Better than handstand.
It shows you a little bit about what the cash flow looks like, and that coincides
Right.
with the necessary capital costs.
Right,
It gives you a sense of the cash flow. but
Right.
I'll let
Yeah,
you
so
take-
there's 2 points. Tell me if I got this wrong, but my understanding is that if there was a commitment to be made, there wouldn't be a commitment made for, so I'm just using the central health portion, right? If there's $1 million coming from central health, there wouldn't be $1 million upfront for 5 years made commitment today. It'd be broken out over 5 years. So there'd be only
Right. Annual
$200,000 committed at any point in time. And then we'd have to go back next year and see if,
point of information. In fact, legally, we can't do that.
exactly.
We cannot commit future boards of managers. All we can do is budget annually.
Exactly.
We
So
spent, tremendous time with the staff at the city and the county talking about what happens if you don't, fund
We
it in
can't,
the
I
third
mean,
year. You
we can't do that.
So that's the difference in commitment there is $16 million over 5 years upfront in contract, where as Sharon just talked about, it'd only be $200,000 for this year, then we'd have to do the same process next year, right? So there's a decision point. The payments for the health metrics, the first one will happen at month 36, and then it'll be annually thereafter. So it'll be 3 payments point. 36, 48, and 60 will be the payment points for healthcare as part of this project.
So,
Holly, I'm sorry, Holly wants to say.
if the board wishes, we could go into closed session
Yeah.
and talk a little bit about what it looks like in the contract, our
I think that's good.
obligation, and what the ramifications are if in year 2 we didn't put up that money.
Okay.
Before we go into closed session, can I
Yeah,
ask my
please
final
finish.
2 questions?
Sure.
One, I just want Because I think, Holly, you said this, but I would like for y'all to put on the record that the contract binds you from telling us who the investors are.
You have something
Come
to
on
say,
up.
ma'am?
Okay, so with the contract, and you should
And
correct
who
me.
are you
Who are
and
you?
who are
I'm
you with?
sorry, I'm Hannah Jamal with Social Finance. I'm a colleague of Nirav Shah's. I believe the language in the contract in section 4.2 states that Social Finance is required to get disclosures from funders before we can share names.
Okay.
So once we have gotten the disclosures
Then you
from funders, then we are
Then you
able to,
can.
but without those disclosures, we are not able to share those names.
I think that would be really important for y'all to get disclosures prior to us making a commitment to invest. I really do. I think it's just it's a layer of transparency that's not being afforded to us right now.
If we don't have your commitment,
Then they can't.
You're not
we
gonna get
don't
any
go
investors.
forward
Chicken
with
and
the
egg.
investors at this level, like,
It's just a
Yeah.
weird way of putting it. I mean, I think you could probably get a disclosure from them that says, hey, we'll get this funding if you allow us to share that you're going to be an initial investor. I don't see why you couldn't, move it forward a little bit in time.
We can talk to our council to see if there's a letter of interest or something we can do to share who's at the table. I cannot say right now we can definitely do that, just because there are rules and regulations of how we have to raise capital that precludes us from, at certain times, giving out names. But again,
Yeah.
sequentially, the contract that will be signed by payers to say that I'm willing to pay X price for reductions in Y sets the term for an investment. And so the investors are not going to pledge their money before it's known what the terms of the investment are. So
I
there's a little
get
bit of
that,
a
but
chicken
I don't
and
see
egg.
why they would want to hide in the shroud of secrecy that they're even looking at this. I mean, that's problematic. It's problematic that they wouldn't want to just say, yeah, I'm looking at this as an investment.
I can't speak on the behalf of the investors we're looking at. Me personally, I can see a reason where if I haven't made an investment, I'm just considering it, I might not want the world to know that I'm considering it. But again, that's me personally. I cannot speak on behalf of the investors. I'm happy to go back to our council and see what we can do if
See
we
what we
can
can
share
find out.
we can share something.
I think the difference between what we do normally, because we're a financing organization. It's usually our partners are
Clear and transparent.
are not-for-profits and they're governmental entities or they're federally qualified health clinics. The difference is we aren't working with people who have an expectation of a return. And there is, I gotta be honest, there's an expectation of return. People don't invest in something, they don't invest $11 million. They don't put $11.5 million on the table without some
Upfront.
expectation of saying, okay, we might lose it all. That's not a wise investment. It's not. And for us to
These
say
are
that they're
also
gonna
people that-
lose, I don't think that's not living in the world of reality, because people want to have some sort of return
You
for
know, I
$11 million.
think- Let me just say something and these guys are more the experts than I, but investors fall into different categories. And there are investors that invest in community work,
Philanthropic.
and what they're looking for is different. And so I don't know that we can assume that an investor that I hear you thinking of big money investors that are not interested in doing social conscience and aren't particularly looking for that. I'm not sure that that's the group of people that we're talking
And
about
I'm
here.
not saying that either. I'm
Yes,
just
but
saying,
you-
but if
but
they
you
are,
are.
if they are the people who are truly interested in social impact and
Put it
change,
out there.
then they would be willing to share that, yes, this is something I'm looking at. And I'm really proud that this is the type of investment that I make. But for us to have a clause right now that prohibits y'all from even disclosing that to us, I think y'all know, we get bombarded all the time that we are not transparent in what we do, constantly, from people in this community. And that is, again, another layer that, you're just gonna give money to people that you don't know who they are? And I
Again,
guess that's the answer would be, yeah, we are, if we make this decision.
Manager Oliver, let's see, we have some comments around that.
No, I was just
And
going to say,
Jen.
I think that our legal counsel had a good point, because it occurred to me earlier, Mr. Chairman, Mr. Giesel, when you said, at some point, Mr. Giesel, am out of this, and, and if you make a decision, it's turned over to our legal counsel. And so I think it would be good to be able to have a conversation with her, given what you told us.
Got it.
That's all.
Mr.
Thank
Jones?
Yeah, I would just say, one is, I agree with you, we would want transparency.
Right.
concern I raised, though, is that I have some questions about some of the transparency we have already with some others, so
Right.
that's not necessarily.
Agreed.
Having said that, though, this timeline says we go back to 2016. I've only been here since 2018. So we've had more than adequate time to have vetted this, studied it, come up with recommendations, addressed many of the questions that I'm hearing here tonight. So I guess my question is that for the benefit of our guests also, are we going to move on this process, or are we using this as a mechanism by which not to do that?
No.
And if we're not, then let's be honest with folks and say, we don't want to do it. But at some point, we need to, and move the process along.
And I agree with you, all right? But this process is not to stop it, all right? This process is to get us informed, okay? The only way that we can put it to bed is for this body to take a vote.
No, I understand, but
Right.
we've been at this for almost
No.
4 years.
Well-
I mean, the discussion from conception up until now.
I haven't been ready for
I-
this either.
I'd like to respond.
Ms. Valadez.
So, Manager Jones, if you'll really look at the words that are used in the Pay for Success timeline, they were having conversations with staff, not with the Board of Managers. We did not know about this until it was presented to us last year as a Board of Managers. We did not have access to that information. Who had access to information, if you'll notice, it says Central Health, which I'm assuming is staff, CCC, the leadership meetings, that's not, I don't see anywhere here that it
Well,
said
the
that they
Central Health
came
is
and
not
talked.
the board.
Central Health Board of Managers is not who was included in the meetings. If I'm correct. Is that correct?
No, Mike we did the timeline. So in essence, I think she's correct, Mike.
I know I'm correct. We were not brought in until the last minute, to my knowledge.
Yes, Mike.
So Manager Valdez, I can speak to more contemporary times, and that is,
Well-
I think the first conversation that I remember was was actually late 2017. But I can't remember if that was a committee meeting or a full board meeting. But then, I think even prior to that, I'd have to defer to some of the staff, but it's brought to my attention that I think that there have been some discussions at the board level about this, but nothing to the extent like where we are now.
Ms. Greenberg.
I was just going to ask, since this predates many of us, and I think you answered it, maybe, there was staff who was here at the time who could answer that question. But it sounds like what you've said is there were, according to staff, there were discussions for the board, but as you noted, not at this level of detail. Okay,
And we
that was
were-
my question.
And
Thank
we
you.
were on the board in pre-2016.
Some people were and some were
No,
not. as far
I'm talking to
as-
Sherry and myself and Dr. Samora.
I just think it's for the benefit of the community,
So
for the
that's-
benefit of the.
So for the benefit of
our
their knowledge.
partner, for the benefit of the board, we need to either put some timeline and move this process along. Either way, I just think that's, because I think that there's pending questions in terms of your ability to do something based upon what our decisions are.
That's correct.
And
I just realized the city only voted on this last month. Not
That's
even
not
quite.
accurate. We agreed to this last year.
Yeah, so it's not
So
like it's been
we made a
3 years.
commitment very early on. We have a step process to go through, as you know. But we made a clear commitment early on, and then we just voted recently for the next phase of the commitment, so.
Well, that's
It
what
was
we
not-
did last year. We did an early commitment, and then I guess it'll be coming
No,
back
but-
in the next board meeting.
But we
or two.
were a yes at that point. We weren't a consideration, we were a yes at that point. So we made a commitment last year.
Well, this says the Board of Managers adopted a resolution to support and direct city managers, so on and so forth. So that's giving consensus that we're headed that way now. So the question is that's been over a year now.
Yes.
So,
I understand what you're saying.
Yes.
And I think that we will move forward, but we had to have this discussion first.
And we
well, I agree
were,
with you,
and
but
we
but
were
I'm
also
just saying,
looking.
how much longer are we gonna need to
Well, I
proceed
don't
to-
think we're gonna need much longer,
No.
for sure. Yes.
Yes, sir. So this is a much different approach for us, and I've apologized to Ann before, and I'll do it here again. We really didn't have an established business diligence approach and a team that sits around accepting proposals every day and they process it. So we've had to fit this one into the cracks, but there's been a lot of going back and forth to first understand, what's this program gonna be like? So for the transactional costs that you saw, what's the additional value here? And really understand, not just from a financing standpoint, but from affecting the lives of individuals, how is this gonna be new and different? Then once we got through that piece, and that took a long time, as you can see in the timeline, then I started looking at it from the standpoint of the investors to say, okay, how does this financial model really work? And what are we going to have to do to be able to make good on this payment to the investors if the savings aren't there, for instance? And that's a business diligence approach as opposed to an appropriations type approach, where you come and you ask a governmental body for money, there's a PowerPoint presentation, and there's an up or down vote. So, and I would appreciate some guidance from this committee and the board. This is not the first time, nor will it be the last time that we've seen this kind of request come forward. I'm thinking recently of the one around AISD and Integral Care, but I think that's what builds a lot into our timeline. I ultimately take responsibility for that, but if you all want to take a different approach, then I think that's probably a little larger board discussion.
Thank you, Mr. Giesman.
Last thoughts.
Okay, I'm wanting to wrap this up. We've 2.5 hours now, and I know. So, very short.
Very short.
Extremely short.
That's right. So as we look at, if people are throwing the term social determinants of health around, you know, here we have been, we know who's in the jails. They're black and brown. That's who's in the jails. The people who are in the community are mostly on the streets. Again, those with mental health and behavioral health issues, medical health issues, people who've been displaced and gentrified out of town. And those are people of color. We also know that we have great inequities in the allotment of resources by all the government entities, including the school districts, for not supporting our
So
family.
what does this have
One
to
more-
do with the project,
Okay, so
please?
with respect to that, we do know, each and every one of us, clearly where the inequities lie and why they lie there. And what I would like to see happen as a result of this conversation between us and all of the elected officials, okay, is that we do come up again with that comprehensive plan that's going to address strategies that need to be put in place so we can close those disparities gaps. That's why we were here. And that's why I feel I'm here, because I want to address that at least at this level, okay, between us. But in taking that, in saying that, I'll look at this, I'll give it a second thought, but I'm going to also look at what the needs are and what I believe, and what I think the priorities of Central Health, and according to our mission and to statute, are. And if this fits within the confines, then okay. But I will want to make sure that what we do is establish a process for future purposes, that we do not entertain any more entities coming before us unless staff is prepared to give it to us and say, okay, here, now take action on it.
Yes.
And that we have that in
want a
time.
process before
I
it
want a
comes to
process
us.
before we come to
I
a
got it.
vote and are asked to take action, because I think that what you're doing is you're creating a situation whereby we're learning that if this has happened before, well, it needed to have been stopped, and so let's take care of business so that we can conduct business and work together to close those gaps. Thank you.
Thank you, Ms. Valadez. Ms. Musa.
I know this is not part of the agenda and illegal. There's gonna be a winter storm.
If it's not,
No, there's gonna be a winter storm, so if we can.
oh, the winter
expedite-
storm.
Sorry,
No,
this
the
is not
thunderstorm.
permitted.
Thank you.
Sorry,
Yeah,
hail.
hail.
So I just want us to
Hail.
leave as early as
Hail,
Councilwoman
thunderstorm.
Kitchen,
for our safety.
Councilwoman Kitchen, thank you so much
Thank you all.
Thank you very
for
much.
coming and having this discussion.
And we appreciate the information.
Thank
Thank
you.
you.
Navab, thank you very,
Yes.
very much. We
Thank
really
you.
appreciate it. Okay. Next item is, oh, do we need to go into closed?
If we're gonna bring it back next week,
We'll bring it back next week, yes.
I won't be here next week.
No, we were
We
not,
can
we were
be
gonna
here
try
back
right out in
next
The
June.
vice chair can take care of,
In
take care
June,
of it.
I'd like to have a
Wait
full
till
board
May.
here. We could do this in June.
Yes. We'll figure out that, okay. We're gonna take a break. Do I still have a quorum?
Fine, yeah.
Yeah, we're in the room, we're in the room. There's 5 of us.
Remember, that's why my amendment has to
That's
go
why I
through.
said, I thought that was a practice that we had in place already though, Dr.
Well, I
Brown.
appointed
No,
myself to the
but
committee
the
already.
bylaws were changed, and so that practice can't happen.
It can't happen anymore. That's next week. That's
Right.
next week.
But I don't have a quorum. So, you guys can break and go eat. 5 minutes, we'll recess for 5 minutes.
I get another phone call, sorry.
All right.
Dr. Z.
Thank you. Okay, we are out of recess. It is 7:47 PM, and I would like to lay out agenda item number 2, receive and discuss a report of the March 2019 financial statements for Community Care Collaborative. Lisa Owens,
Good evening, Lisa Owens.
thank you for sticking with us.
All right. Just quickly, I'll hit a few highlights that we'll go through when we go through the documents. We'll highlight that the cash is at 39 million compared to 69 million last year. And again, we've talked about this for several months, the variance being due to the timing on the DSRIP payments with the program changing to a calendar year. Net assets at the end of March are 17 million. Liabilities at 22 million, and as we've talked about as well, we made some changes to the budget. We made an amended budget this month to highlight the changes we made in the past to the post-acute care. So on the balance sheet, again, we have $39.8 million in total assets, predominantly made up of cash, with small amounts in other receivables and prepaid. Our liabilities total just about $22.5 million, again, mostly made up of provider incurred but not reported costs, which is our providers delivering care. Small amounts in deferred revenue, other liabilities, and accrued payroll at the end of the month. Net assets at 17.2 million, a total liability and net assets at 39.8 million. Our sources of funds and uses of funds. Sources of funds, we have DSRIP revenue year to date. Again, that's at 32 million, which compared to last year, the timing on the DSRIP revenue is off, but we anticipate that in June, early July. Member payments totaling 25 million. And other sources, which is predominantly interest, just under 300,000 for a total sources of funds year to date at $62.7 million. And our uses of funds in our main program of healthcare delivery at $42.3 million, which I'll go into more detail. And then our DSRIP project costs at $8.175 million. Year to date. That is an estimate based on the reporting that we receive monthly from the providers of those programs. That is not anticipated to go over budget, but the timing on when the milestones and outcomes are achieved is just hard to tell. So that's our best estimate given the great reporting we get from our providers. Total net sources over uses, uses over,
It's a long night.
Is it 8 o'clock?
Take your
Yeah.
time.
Uses over sources.
10 minutes left.
$12.2 million. Okay, healthcare delivery, as I mentioned, is at about 45% of the total budget, $42 million out of our $95 million budget in the main program in the CCC. You'll notice we added the approved budget and an amended budget after the conversation about making a shift into post-acute care, and we highlighted with an asterisk where you can see that we increased the post-acute care to $1.7 million, and we decreased our healthcare delivery operations, and there's a little more detail on that last slide to go through that. So we have additional slides on primary care and specialty care and healthcare delivery operations. Otherwise, our post-acute care, as we mentioned, we did increase that with a budget amendment to one of the providers, contract amendment to one of the providers in the past, and we are carefully monitoring that as the program continues. And that is at about 58% of budget. We are 6 months through the year, so just a little bit ahead, but again, we are closely monitoring that. Urgent and convenient care also at 66% of budget, but again, that is based on the demand and the utilization, and we will keep an eye on that as well. So going into more detail on primary care, which is about half of our healthcare delivery budget, we have year-to-date is at $25.4 million, which is about 49% of budget. And you'll see that most of our providers are right on track, around the 50% mark, with the timing on some of our smaller providers being a little varied. Total primary care, again, at $25.4 million. Specialty care. We are really excited, a lot of work into this slide. I'm looking at my team over there. you know, as the CCC has developed and the specialty care program has become more detailed, and we've worked with our providers to provide more details, we've really been able to show more by type of specialty, those dollars approved in the budget and then spent. So one thing that I just want to highlight is that last year we did have all of the community care, specialty care in one line item. So we have the prior year to date matched up with what we reported to you last year, but that is now shifted now into things like pulmonology and different line items. So we show that for last year, but that shift has been made, so we'll focus on the approved budget and the year-to-date actual. Again, we are at $3.3 million out of our $10.6 million. That is about 31% of the total budget. And again, we are closely monitoring that in regular meetings with John's healthcare delivery team and service delivery operations team to work with any of the contracted providers in those specialties to make sure that as we get past into the the third and fourth quarter of the year, that we're monitoring any contract amendments that may need to be made. But at this point, really just keeping an eye on the services being delivered and the reporting that we're getting. So again, $3.3 million out of our $10.67 million budget has been spent year to date. And finally, on the healthcare service delivery operations, again, made slight amendments to the budgets. You'll see that $300,000 of that $500,000 that was moved to post-acute care came from our claims payment and analysis department. $100,000 from project management and $100,000 from quality assessment and performance. Year to date, we are at about 30% of the total budget for this. Again, this is a lot of our operational departments, joint tech, health information technology, eligibility enrollment, and our claims processing. Those are the departments that make up these areas, and you'll see each of the operating departments is well under the 50% at the 6-month mark, totaling 30% of the budget at just under $3.8 million. With that, I'll answer any questions.
Thank you very much, Mrs. Musaiti.
Slide 7. So under oncology services, what are those services, can you remind me?
I'm going to have John come up and talk a little bit more about oncology.
Yes, please, John. Appreciate it.
Good evening. John Morgan, I'm the Executive Director for the CCC. So oncology services is made up of two different items for us. The first is radiation oncology through Austin Cancer Centers. The second is, and the reason why you're seeing that fairly below budget, one of the reasons is that we have new initiatives there related to FIT testing. So colorectal cancer screenings as well. Colorectal cancer screenings makes up about $200,000 of that amount. And then the remainder, 500, is Austin Cancer Centers for radiation oncology for our patients. As it relates to Austin Cancer in particular, we are seeing lower volumes of services than we did last year, but we are seeing service levels that are more in line with 2 years ago, leading us to think that last year may have been a spike in oncology services that we needed to provide for radiation purposes.
So if you were just like, do you know what the diagnosis, what type of cancer was it? That you had?
It's multiple cancer diagnoses. It's any cancer diagnosis that requires outpatient radiation therapy.
So you mentioned that last year you saw a spike in which type of
I
cancer?
don't know the answer to that, but I can certainly find out.
Just out of curiosity. So, okay, thank you.
Thank you. Mrs. Valdez, please.
Hi, thank y'all for being here, thank you for your report. With respect to, I guess I'm gonna start with page 4. Under sources of funds, member payment from Seton. Year-to-date actual, approved budget is 40 million. Year-to-date actual is 15 million. Is there a reason?
So I think the first thing I'd point out is that the contributions to the CCC are discretionary by each of the member organizations.
I know that.
Secondarily, I'd say, I think that both of the members take into consideration the cash flow needs of the organization and try to make sure that we have sufficient cash throughout the year. And each of the members, on their own takes into account the cash needs of the CCC, and they contribute as a CCC needs additional funding.
So, year-to-date actual, for the budget, I'm trying to remember so I can get a good idea as to whether or not they came in at the approved budget amount, their contribution. The prior year.
I would have to look that up, but I can get that for you and follow up.
Thank you, I appreciate that. And then, with respect to page 5, under post-acute care, that was what you were talking about in the previous slide, correct? I think 2 slides prior to this. I just want to make sure clarified. And on page 6, the People's Community Clinic and the UT School of Nursing, what's happening there?
So 2 different things there, and I think I got a similar question last month from Manager Greenberg about UT School of Nursing, so I'm happy to address
Yes.
that.
Yes.
You did.
I think with...
Is that a trend?
I'm sorry?
Is this a trend?
It is a trend. So let me start with UT School of Nursing. So I was asked to provide a little bit of background and
Right.
just some insight into where we are and where we're headed with UT School of Nursing, so I'll try to be brief. That agreement started in June of 2017. We partnered with the UT School of Nursing both in order to provide access to our current MAP patients that are receiving services at their 2 sites, Family Wellness Clinic here on I-35, and then the Children's Wellness Clinic out in Del Valley. So this was really put in place to cover the circumstances where a MAP patient happened to be getting services there. We did expect from the beginning that those service levels would be fairly low. And what I can tell you in terms of forward-looking is we are in conversations since our last meeting. I've had a few discussions with Dr. Morgan. I'm actually meeting with her again tomorrow morning at 8 o'clock. And we are talking about ways that we might adjust our contract so that we can encourage more service volume from them in the future. There are also other facility expansion opportunities on the horizon with UT School of Nursing. We're having those discussions as well. So we have this contract and intend to keep it in place in order to take advantage of those future partnership and expansion opportunities for our patients. Historically, since we executed this contract in 2017, it's really a handful of our patients that go to those 2 facilities on a monthly basis.
I remember us having the meeting with them out there.
Yep.
But is this also going to be aligned to the future expansion on the Eastern Crescent? Is that what we're talking about?
That is one of the opportunities that we're discussing with the School of Nursing.
And the other?
No, that's the opportunity. The other opportunity is changes to our existing contract so that we can encourage more services there.
So down here on 35, and that's in
Yes,
the
ma'am.
parking lot of the Sears?
I think it's across.
The ex-Sears?
It's across the street from that Sears complex.
Oh, so they moved their building? They moved their little building? I'm just curious.
I think that they've always been on the northbound side of I-35.
It's,
Finances, not where the location of the.
Oh, I'm sorry.
Finances, yes.
I'm happy to follow up outside of the meeting.
thank you very much, I appreciate it, thank you. Thank you, Dr. Bell.
Sure.
And I think that is it. Thank you very much.
Thank you.
Oh, one more, just kind of clarification. Health information hit health information technology budget and then IDS. I know that this has come up in questions that I have had with respect to the technology alignments between us and the other, the 4 clinics. And I'm not going to throw the name out with respect to Matt Basic, but what is the distinction? Okay, what is the change? I know when we were talking about originally funding to the tune of millions of dollars, this integrated delivery system and investments of millions of dollars in servers and things like that with respect to our software component, our hardware component, all those kinds of things. Where are we there?
I'm not sure that I know what you're referencing.
I don't think
Well,
that's
with
it.
respect to
Your
ID,
question's
because it's
not
IDS. Oh, so,
So
I
that-
guess
that
what I would
line-
need to do is have an offline conversation maybe with you, Lisa, and Jeff.
I think so.
Because, you know, we have had presentations originally in previous budgets where we were talking about millions of dollars invested in the development of an IDS, not only by our partners, but also by Seton.
Right.
And so I want to make sure that I'm understanding the distinction,
Offline would be great.
okay?
Appreciate it.
Thank you very much.
Shannon, did I see your hand?
I just had a quick minor question. On that item with the other, under primary care, other providers, 1%, what's going on there?
So this is actually two things that are combined into one line. Good question. The $400,000 approved budget was the set aside in the CCC budget related to the Pay for Success proposal.
Oh, so here it is, here.
So it was
Yep.
set aside in our 2019 budget process.
Okay.
The $2,850 is actually the run out of our YMCA agreements related to the the diabetes prevention program that we were contracted for in 2018.
Okay.
So we wanted to continue that pilot, make sure that all the patients that were involved in that program were able to complete the program.
Okay, thank you.
Yes, sir.
Thank you very much. Thank you. We appreciate your presentation and John answering all of our questions. I'd like to put out now agenda item number 3. Receive and discuss a report of the March 2019 financial statements for Central Health. And again, it will be Lisa.
Okay, so a few highlights from Central Health. With March coming to a close, that is the kind of last bigger month of tax collection. So we have collected about 99% of our tax revenue, 98%, at $195 million. And compared to last year at this time, the difference is largely due to the increase in budgeted and planned tax revenue. The other highlight I would just say as a use of funds in March was a IGT payment made for the disproportionate share program, which was an advance into that program. So looking at our assets, again, highlighting the total current assets are $14 million over last year, again due to an increase in cash from tax revenue being collected. Non-current assets, $121 million. $108 million of that is the combination of the Sendero paid-in capital and the Sendero debenture. And then finally, no major changes on our capital assets. Our total capital assets for the month are at $113.9 million for total assets of $402 million. On the liabilities, fairly low liabilities right now at $8.2 million in current liabilities, predominantly made up of deferred tax revenue that we anticipate coming in over the next several months, much slower pace, and accounts payable and salaries payable. Non-current liabilities is our long-term debt at $7.3 million for total liabilities of $15.5 million. Total net assets are at $386.7 million, so again, for total net assets and liabilities at $402 million. Our sources and uses, at the high level, the sources of funds this month, property tax revenue, again, about $1.4 million coming in as the property tax will start to slow down the pace of collection towards the end of the fiscal year. Lease revenue, we did record our monthly lease revenue from Seton for the parking garage and for the UT ground lease. However, you'll notice, if you remember last month, an increase in that line item as we had our annual rent payment from the 2033 fund for that first lease payment of just over $900,000. So that's a one time a year payment. So that year-to-date lease revenue is at just over $6 million. So $3.5 million of sources of funds coming in through the month of March. Our uses of funds total just under $8 million, which the bulk of that being $7.5 million in healthcare delivery. In our administrative program, $566,000 in administrative program, mostly made up of salaries and benefits. And I would just highlight that again, we are halfway through the year, about 50% of the way through the year, and our administrative program with our budget of $9 million is at 34% of the budget. So. Total healthcare delivery, as I mentioned, is $7.5 million. IGT to the disproportionate share program of $6.1 million. And then on the provider cost, we had year to date about half of the primary care cost for the Planned Parenthood program has been expensed. And this month we also had medical administration, which is our participation in the ICC. Total there in provider costs just over $66,000. On service expansion funds, we'll be working on highlighting this a little more detail in the future months as we just started to see dollars in this space. The total there of the $4.4 million in service expansion funds includes new initiatives as well as women's health. And so we're going to break that out in a little more detail going forward as we've just started to see some expenses. But our estimate there of $174,000 is for our LARC program, so we're excited to be having those services delivered. So total IGT and provider costs at $6.4 million. Total healthcare delivery operating costs, salaries and benefits. Again, in this area, I've highlighted this the past couple months. Last year, as the region's RHP 7 anchor, we get a reimbursement for expenses, and the last year, that is driving down the expenses, so the year over year is a little off. But we are well under budget in healthcare delivery operating costs at just under $3.2 million of a $9.5 million budget at 33%. Other costs, you'll see, you are going to start to see things starting to pick up with the campus redevelopment. That does include the operations. Again, we're operating the full campus with utilities and security. As well, we're starting, the abatement process is well underway, and then the CEC Utilities project is working, is getting up and going. So those expenses, again, at 20% of the $11 million budget, are going to be a lot more variable this year as we have things like the abatement and the utilities happening, and hopefully other things starting to move forward on the campus. ACA enrollment and subsidy, that does include the CHAP program as well as the high-risk program, and so you see just over $438,000 in premiums paid this month. Again, a total of $2.7 million year to date. So just getting down to the very bottom, our total healthcare delivery, again, $7.5 million. Total fiscal year to date at $120 million. We're at about 48.5% of our annual budget. Our last slide is just a highlight of the IGT year to date. Again, we made our disproportionate share IGT in March, and our year to date IGT is $77.9 million. And again, I'm happy to answer any questions.
Thank you very much, Lisa. Appreciate that presentation, Ms. Halliday.
I think I only have two.
That would be great.
With on page 5, other purchased goods and services, what's an example? Just-
Other purchased goods and
Yeah.
services, so that's gonna be everything from utilities to office supplies to
Got it.
everything that isn't legal
Got it.
consulting or salaries and benefits that it takes to operate.
Got it. And with, on page 6, the next page, ACA enrollment and subsidies, and I know that you said that that includes CHAP and other things. Does it include SIMS or HAM?
That is the CHAP program. So the
That's your CHAP program.
The Central Health, I refer to the CHAP program, which is our traditional program that is with SIMS and HAM. And then the new program, I was using the term ACA High Risk, which is the new enrollment program. that's
Correct.
there. So yes. that
Is
does
it possible to have an offline conversation with respect to that?
Yes, certainly.
I appreciate it.
I'll
Thank you very
follow
much.
Thank you. Appreciate that. Made my night. Thank you very much. Any
Thank
other
you.
questions? Thank you very much, Lisa.
Thank you, Lisa.
Item number 4, receive and discuss a presentation on fiscal year 2020 strategies that support the development of the FY 2020 Central Health budget. Lisa.
Okay, so I want to reintroduce Melanie Miller.
Thank you.
Thank you.
So this is very short, we're really here to just get you guys ready for budget season.
Yeah.
I know, you're excited. But Melanie and I have been working, Melanie's ready to go. And the very first part of building our budget is aligning what is going to be in the budget with what our strategic work plan initiatives are. So what we wanted to just highlight for you today is a page from last year's budget booklet, which highlighted last year, and we are proposing and will continue to drive these forward this year, the strategies that are going to be highlighted in the budget. And again, this is not all the strategies in the strategic work plan, but these are the ones where we have our largest investment, like determine the optimal use of the Brackenridge campus and those areas. So we wanted to bring this back to you just as an opportunity in advance of our community conversation on April 29th to let you know that this is a 2-year work plan. So we are continuing forward with the same strategies as we still have a lot of work to do in some of those areas, and we've made a lot of progress in some of those areas, but we will continue to highlight those same strategies.
Thank you.
Great. Do I have any questions? Thank you so much. Appreciate it. All right, item number 6, discuss and take appropriate action on Central Health-owned or occupied real property, including the downtown campus and properties located in eastern Travis County. Mr. Geisler.
Yes. Members, I have 2 brief items for you under this agenda item. One, we have notified the 2033 fund, and this relates to the Brackenridge campus, that we have vacated the professional office building that is also known as Block 164, and that we have completed all asbestos abatement and removed all the necessary equipment from the professional office building. As a result, and this is per the agreement that we have with 2033 fund, then they will now prepay 3 years of base rent for that particular block, and that equates to approximately $1.8 million that we're expected to receive mid to late May.
That's 3 years of rent,
Yes, 3 years of base rent.
a base rent,
Yes.
yeah, okay.
Yes.
Great.
The second item relates to Austin Colony Hornsby Bend. This afternoon, we heard from the city regarding a site use exemption that we had put before
Requested.
the city development services department. And just to try to explain this briefly, anytime you go out to a site, you want to put something down, you create impervious cover, and those of you, I
Right.
think, understand that.
Oh,
But
yeah.
even though this is a modular and temporary for public health purpose, we're still, and because it's in the ETJ, we're still subject
Responsible.
to those requirements. We heard today that they're not going to grant the exemption, and so that would potentially throw us into a multi-month, we think anywhere from 6 to 8 month approval process. Mr. Lamp is working with our engineering firm, and we've talked to the city department today to see is there anything we could do to get that exemption, because it gets us on the ground that much faster. We've already identified a firm from which we'd like to purchase the modular, and we've worked with the ESD. We have a business plan that's been submitted by Community Care, so all these pieces are in place except for that site exemption. And again, I just wanted you all to know about this. I need to circle back around. I've already talked individually with some of the community members out there and let them know that we're working with the city, but I need to circle back around with the advisory committee and the community out there to let them know that it looks like we're gonna have to amend that site plan in order to be able to get that exemption and get out there faster.
I just have a question
Ms. Valdez?
with respect to that. Is there a problem with a runoff, with a retention pond? Is it not a flat surface? I mean, what appears to be the reason for them negating the waiver request?
I'm sorry, if I said waiver, I meant exemption request, site exemption request. It's about just the amount of impervious cover. So
Yeah,
it's-
well,
it's the
yeah, the
rooftop,
percentage.
it's,
Yeah,
When it runs off, the rain
just the
runs off.
percentage.
if you have gravel that's used for a walkway,
It's
that's
pervious,
not
impervious
counted. If you have gravel
percentages.
that's used for a parking lot because it's
I know.
compacted, that's counted.
Right.
And then you've already got hard concrete sidewalks out
Yeah.
there, which you need to have to make it ADA accessible. So there's, once you add up all the amount of
Yeah.
impervious cover, then we're over.
The percentage of land
Yes.
limit.
Right, and normally that's done
now.
because of the runoff.
And speaking with the city today, they indicated to us they did have some flexibility, but we'd have to reduce the size of the modular, which we've looked at.
The footprint.
Yes, ma'am, to be able to give them enough comfort that we're not creating an undue, I guess, drainage or runoff problem.
Yeah, it is. Okay.
Great. Anything else?
And this is the new
Miss-
site,
Miss
correct?
Newsighton?
I'm sorry, there was a follow-up question.
Yes, this was the new site, because it wasn't
This
the
is a
original.
temporary site.
Right.
We're only hoping to be out there for 2 years. We've got an option to take it to 5 years, but it's a
Okay.
temporary site.
Okay, thank you.
Thank you. Ms. Newsighton?
Thank you. If I'm hearing this correctly, so this will delay services?
Hear you.
Oh. So if I'm hearing you correctly, so they're not, the lack of exemption, correct, will delay services to the eastern, to Del Valley?
Well, first, we have a home visit pilot specifically for that zip code in that area
Right.
that we're talking about. So this is Austin Colony, Hornsby Bend.
969.
725. And I know we've done some initial marketing. We have a second phase, if you will. That's my phrase. But Ted and Community Care have talked about this. The appointments were kind of slow starting out, so people are getting care. But they're also being seen at other community health care centers. We estimate over 1,000 patients are receiving services, just not there. So in addition, between being seen at other community health care centers and also the home visit program that's dedicated to that area out there, they are receiving services. It's just,
I understand they're receiving services, but we want to expand those services. Now, if there's a delay of up to 6 to 8 months, we have to think diligently about probably adding additional route services, or I think we're utilizing Lyft, but I don't think this will come very pleasant to those folks who have been asking for services, and coming that our budget season is coming around the corner, this will not do them good. I just want you to be cognitive of that.
and I'm personally engaging with members of the community out there, both on an individual basis as well as the larger team, when we come together for our community advisory meetings. But plus we have email going out, but again, this is something I need to circle back around on our email distribution list and with our community advisory team to let them know what's happening. The other thing that I want to impress upon you, we're not taking this sitting down. Just because we've been told it could be 6 to 8 months to go through the
may not be.
longer term approval. We're engaged right now with the city to figure out, how do we get this exemption? Even if we have to shrink the clinic footprint size.
You
How
just
do
need
we
to get
get
to a
this
number.
done?
Footprint,
It's a number, it's a percentage.
right.
We can get something out there for
That's
a couple of years. We're already working on a longer term solution out there.
So, what are we talking about in terms of footprint? That the exemption is, what's the debate? What's
Originally-
negotiable? How much of
Originally, we
the
were
percentage are we
looking
going
at,
over?
I don't have the percentages in front of
So
me.
is it like we're going over 20%, 30%? Like, I just want to know what the number is. I think that would be helpful.
It's
But
a ratio.
Well, it was,
is it
it was enough over to get a disapproval for the exemption. That's really all I know at this point. I'd have to circle back around with
So maybe
Mr.
offline
Lamb
we can
to
get
see.
more.
Look at the site plan.
Yeah,
Okay, well, I just
Yeah.
wanted to make sure that we're cognitive about this issue, and delaying will not solve. I understand the barriers. Thank you.
Thank you very much. Mr.
Just
Jones?
two quick questions. One this is in the city's ETJ?
Yes.
Yes, sir.
Because that's why we're having
Yes.
to do this.
That's
Yes, sir.
Okay,
exactly
is the
right.
permanent plan to be in the city's ETJ?
The permanent location?
Oh, I understand.
Permanent
what you mean.
location.
Yeah,
Permanent
so
location is
based-
ETJ or
Well,
not?
based on,
And then what are they planning on annexing?
based on the landowner that we're talking to, yes, that would be in the ETJ.
It's still there, okay. And just one other option, you may want to consider reaching out to Stephanie Hayden, the director of Austin Public Health, as an agency of the city of Austin, if they're going to be be part of this, and I don't know if they're going to be in there or not, the possibility of getting an exemption as a city department as part of that might be an option you may want to just consider.
I appreciate that. Thank you, and I will.
Yeah.
Collaboration, that's right.
Very good option. Any other questions? Okay, thank you very much, Mr. Geisler. Our final agenda item, confirm the next regular committee meeting date, time, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is scheduled for May 22nd, 2019 at 5:30. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas 78702. Do I have a motion to adjourn?
Adjournment.
Second.
I have a motion by Ms. Greenberg, a second by Ms. Valadez. All in favor?
Aye.
Any opposed? Any abstaining? Motion carries. We are adjourned. Thank you, guys.
Appreciate it.